Good morning, everyone. Good morning, everyone. My name is Camille Ware, and I serve as the Public Health Coordinator for the National Center for Racial Equity and Inclusion here at Martin University. I want to first thank you all for joining us this morning for the third installment of our Public Health Summit Series conference focused on breast, lung, and colorectal cancer. With an overarching goal of furthering primary prevention efforts within public health, the Public Health Summit Series allows for a wide scope of medical platforms for those in attendance to receive, ranging from firsthand patient experiences, physician-led sessions, and vital community resources. By the end of each conference, participants will have a wider scope of literacy, education, community engagement, and furthered advocacy gained from each health and wellness topic presented in the series. The Public Health Summit Series originated from my own personal passion within public health and wellness, specifically within minority health. I personally am no stranger to chronic illness, and it was conferences such as these that were presented by the Martin Center for Sickle Cell through my life that aided me on how to properly advocate for myself, learn how to take care of myself, and further my own advocacy and being a testimony for others. Without these conferences, my health journey could have been a lot different in every aspect. Within my role in Martin University, I wanted to share in my passion of health equity and its importance of ensuring we bring equitable health resources to the communities that need them. Today is not only for cancer warriors themselves, however, it's for caregivers, loved ones, friends, and anyone else that may take part in a patient's care. Chronic illnesses such as cancer not only impact the patient themselves, however, everyone around them who also deserve the same support and advocacy as their loved ones. Again, I would like to thank you all for joining us this morning, and I hope that you conclude today with a broader scope of how you further become an advocate or maintain your advocacy for lung, breast, and colorectal patients. Next, I would like to go ahead and do an agenda overview along with some housekeeping items before introducing Dr. Sean Huddleston, the president of Martin University. Next, we will have Dr. Sean Huddleston address us along with Executive Director of the National Center for Racial Equity and Inclusion, David Hall. We will then go into our physician presentations. First, we will have a breast cancer presentation by Dr. Nawal Kasim. We will then have our lung cancer presentation by Dr. Francesca Duncan. And then we will have our colorectal presentation by Dr. Thomas Imperial. We will then move into our guided panel discussion with moderator Lisa Hayes, Executive Director of Pink Forever. We will then go into a lunch break, followed by a keynote address from Nadia E. Miller, President of the Board of Directors of Pink Forever, Ending Disparities. We will then go into partner and keynote recognitions, and then we will conclude the conference with the community organization resource fair for those attending with us in person today. Next, I would like to welcome Dr. Sean Huddleston to the stage, Martin University's president.
Glad I lost weight for this. I can get through here. Okay, I'm going to try something. Good morning. Good morning. Oh, wow, y'all got it on the first try. That's outstanding. Outstanding. Well, welcome or welcome back to Martin University. And before I begin my very, very brief comments this morning, I would love it if you would all just take a moment and put your hands together for Ms. Camille Ware. I gotta tell you, and I have to brag on her just a little bit. When we think about intentional pathways and when people turn their passion into practice, when someone says, I specifically want to go to school to study this so I can do this work and make an impact, there's no better example than Camille, who, as she mentioned in her comments, she's had some personal health challenges, and that fueled her desire to go to college with a focus on public health and then find an opportunity to do it as a profession. And so that's our hope for all of us. That's our hope. That's the work that we do here at Martin University, and I could not be more proud of the great work that Camille is doing for us. So thank you, Camille, for your leadership and all the great things that you're doing. I need you to understand one thing, and that is that Martin University, above all else, is a university. That means we are in, of, and for the community. And certainly through education, we believe that there is a pathway to personal and generational wealth. We also believe through education, lifelong education, there is a pathway to personal and generational health. And so our focus with our public health series is to ensure that everyone in our community is able to take this information, take the resources, take the knowledge building that will occur and use it to be able to build community and build generational health. So we're very, very excited. This is very much in line with our mission here at Martin University, and we welcome you to continue to come and support us. We welcome you to continue to come visit us, but more importantly, we welcome you to continue to be a part of this great family we have here at Martin University. I am going to step away from the mic, and I'm going to hand this over to the true subject matter expert in making sure that we're building community the right way, and that is Mr. David Hall, who is our Executive Director for our National Center for Racial Equity and Inclusion. David, thank you.
Good morning, everyone. Good morning, everyone. Oh, okay, all right, you all are there. Thank you so much for joining us this morning. I know it's early, but I promise it'll be worth good information, good time. We truly appreciate you all being here. I appreciate you all for making Camille's vision come true for what this will look like as well. My name is David Hall, and I serve as the Executive Director of the National Center for Racial Equity and Inclusion here at Martin University. And within what we do within the NCREI, we do two things. We do DEI uplifting and community engagement as well. And so within that community engagement, we like to focus on bringing equitable opportunities in areas such as education, public health, banking and finance as well, technology, business development, all these different areas. And so today you are engaging with us in our public health and wellness piece. And so that is headed by Camille, and we kind of thought this up of how can we bring more equitable learning opportunities and highlights to healthcare disparities within the Black community, other minority communities as well. And so it is a pleasure for you all to be here. Again, this is our third installment for what this looks like. We have more of these to come, and we look to hope and grow and be better and be more engaging, and to have even more people come and learn and engage with us and hear from our great panelists and great speakers, and be able to come and share in what Martin University has to offer. And so it's a pleasure to see you all today. Please make sure that we gift exchange, card exchange, all the good things. Please see our community partners as well. And thank you all for coming this morning. Camille.
Thank you, Dr. Huddleston, and thank you, David, for such a welcoming address this morning. Next, we're going to go over a couple of housekeeping items for those that are joining us in person. First, I would like to mention we have a couple of surveys floating around with us today. As some of you came in, you might have taken our registration survey. If you did not, we would appreciate if you do so, just because your results will be used anonymously for research purposes. Next, we also have a community forum survey that'll be provided by the IU Simon Cancer Center, who is back here with us today by the double doors where you entered. I would encourage you all to take their survey as well. And lastly, for those of you that picked up a run of show, there's a QR code on the back of it. At some point during the conference, we would like you to scan that and take our evaluation survey. And we also have them on the screen for those who are joining us virtually. Next, for those of us who are joining in person, restrooms are located outside of the double doors on the right and to your left. Next, we have light breakfast on the table along with waters. For those of you joining us in person, we encourage you to grab it so I will not have to pack it and take it with me. All right, next we're gonna have a brief break and intermission as we prepare for our first speaker, who will be speaking on breast cancer, Dr. Nawal Kasim. We encourage you all to be back with us at about 9:30, so that gives you about 10 minutes. Thank you. go ahead and transition into session 1, part A, which will be our breast cancer physician presentation by Dr. Nawal Kasim. Dr. Nawal Kasim is a board-certified oncologist who specializes in breast cancer for Indiana University Health. In addition to caring for breast cancer patients, Dr. Kasim is the medical director of the Indiana University Health Cancer Prevention Program. As always, we will save questions for the end of her presentation. For those that are joining us virtually, you're more than welcome to put your questions in the chat box, and we will read those aloud once the Q&A session has commenced. So please join me in welcoming Dr. Kasim.
So about 70% of the room. So I'm hoping with today's talk, I can give you all some information about breast cancer to help you and your loved ones take better care of your health in terms of breast health, and also better advocate for yourself when it comes to your breast health. So like Camille said, I'm Nawal Kasim. I'm one of the medical oncologists at Indiana University. So I am the doctor that prescribes chemotherapy and other drugs to help take care of breast cancer patients. On other days of my week, I do research. I also see patients who do not have cancer, but have a hereditary risk for cancer. So things that have been passed down through generations in their family that increase the risk for cancer. Some statistics to start us off with. So breast cancer, we all know, is the most common cancer that women have. And in fact, about 1 in every 8 women will develop breast cancer in her lifetime, so by the age of 85. Now, men think, we don't have breasts, we don't get breast cancer. That is a false statement. It is a lot more rare, but men can get breast cancer. And in fact, 1 in every 1,000 men will be diagnosed with breast cancer in their lifetime. I think perhaps one of the most striking statistic I will tell you about today is that while, is there a pointer on this, Camille? Let me see if I could do this. There's not, okay. Well, while Caucasian women and African American women are just as likely to develop breast cancer, African American women are 40% more likely to be diagnosed with breast cancer. There are many reasons for this. There are a lot of socioeconomic factors that we think about. So things like insurance, access to health care, but there are also other things that make us wonder about the tumor biology. So African American women are known to be more likely to be diagnosed at a younger age. They are more likely to be diagnosed at a later stage, more advanced stage of breast cancer. They are also more likely to be diagnosed with the more aggressive subtypes of breast cancer, so triple-negative breast cancer and inflammatory breast cancer. So some basics before we move on to what breast cancer is and what are the risk factors for breast cancer. Well, I'd like you to think about the human body and how it's made up of 37 trillion cells. And think of the cell as the building block for the human body. So your body is made up of all these cells. Within each cell is the genetic code that is passed down from your parents to you. So you get 1 copy from your mom, 1 copy from your dad, and that is the information that is carried out in each and every cell in your body. And the reason I bring this up is all it takes for a tumor to grow is 1 cell. 1 cell carries on these changes, stops listening to the rest of the body, and it starts to grow uncontrollably. That's what forms a cancer. So when we talk about breast cancer, I have to talk about the breast in general. It's made up of different kinds of cells. So its majority of the breast is made up of fat cells. You also have glands. So if you could see here, they're labeled as lobules, where breast milk is made, and ducts that allows the breast milk to travel from the lobules and out to the nipple. It is in those glands that breast cancer usually develops. And so here in the other picture here, you see where a tumor is. Ways that help us find those cancers is those mammograms that you hear about. We always hear about, get your mammogram once a year. A mammogram is simply, an X-ray. You see here the breast is placed on a plate, and then other plates come together to essentially flatten the breast out so that the radiologist can see into the breast. I have yet to meet a woman who's excited about her mammogram, who tells me her mammogram is really comfortable. These things are not comfortable, but they're not painful, and they don't last very long. So if you've ever been scared about a mammogram, it is not that bad. You may hear the words ultrasound. So what happens if the radiologist or the person looking at your x-ray or this mammogram sees a change in your breast that they're just not sure about? They may recommend an ultrasound, and that is simply a wand that goes over the breast and allows us to see a little bit better. If they are still concerned, so for example, they see some things called calcifications or a mass, they will recommend what we call a biopsy. They use the ultrasound to help us guide a needle to the area of concern, whether it's a mass or not, and they take a sample of this. And that's what allows us to help diagnose breast cancers. So in addition to getting your yearly mammogram, things to look out for. Nipple discharge. A woman that is not breastfeeding should not, in general, have any discharge from the nipple. Milky, bloody, any discharge should be something that you talk to your doctor about. I tell my patients, know your breasts. Know what they feel like, know what they look like. Anything out of the norm for you is something to talk to your physician about. I have examples up there. Things like scaling of the nipple, the nipple pulling in. Obviously a lump, if you feel a lump in your armpit or the breast. Redness of the breast. If you see what we call a peau d'orange or changes that look like an orange peel to the breast becomes heavy and red. Those are all signs to talk to your doctor about. Or if your sister or your aunt comes to you and says, I have this weird looking thing on my breast, can you look? That's definitely a reason to talk to your doctor. I'll talk to you today about some risk factors. So these are things that may increase or decrease your risk for breast cancer. There are factors you can control or can help change, and risk factors that you just simply cannot. I'll focus first on the ones that you can change. So things like breastfeeding. Breastfeeding actually decreases your risk for breast cancer. Smoking increases your risk for breast cancer. I am going to focus on the top three. So alcohol, obesity, and exercise. So when we think about alcohol consumption, what is considered a lot of drinks? And I get that question a lot. Studies have shown that women who drink 2 to 3 drinks per week, or more than 3 drinks per week, have a 15% higher risk of developing cancer, breast cancer specifically, compared to non-drinkers. And I have an example up there of what constitutes a drink. So a 5-ounce glass of wine is considered a drink. A shot of 1.5 ounce of hard liquor is also considered a drink. And that risk goes up with every additional drink that a woman has. As for weight, weight also matters. Yes, us doctors keep getting on you about your weight. It increases your risk for a lot of things, including heart disease, your blood sugar levels, but it also has been shown to be linked to breast cancer risk. The reason is Fat cells produce hormones and signals that can tip cancer cells over the edge. So if a cell is precancerous, it just becomes more likely to become cancerous, and even a normal cell to start changing to becoming precancerous. So that's why it is really important for women to watch their weight. Ways to do this is with a healthy diet and exercise. And healthy diets are harder to come up with at home. So harder to buy healthy food, harder to make your own food. But I think making small changes, it's as simple as adding fresh fruits and vegetables when possible, making small swaps, like changing out the white bread for brown rice or lentils, things like that. And this picture here shows you some other examples. Now, when it comes to exercise, we know that exercise actually helps you reduce your risk for many malignancies, and especially for breast cancer, we know that exercise reduces your risk by about 20%. And when we talk about breast cancer patients, I can tell you my breast cancer patients who exercise before, during, and after their diagnosis tend to do better in general. We know that breast cancer patients who are diagnosed with breast cancer and are exercising tend to tolerate their treatment better. They also tend to do better long term. And I get this question a lot. How much exercise? What is exercise? What should I be doing? And I tell my patients, do anything that makes you happy, anything that gets you off the couch, gets you off your phone. If it's cycling, walking, jogging, I put a bunch of pictures up there, swimming counts. We recommend 5 days a week of 30 minutes each day. Now I know that's very tough. Many of us don't even get to doing 3 days a week, but do what you can. I tell my patients, if you're not used to exercising, walking to your mailbox back and forth, I think that's a good thing to do per day. So baby steps. How much? 30 minutes per day, and you should not be able to sing while exercising. You can have a conversation, short sentences, but you should not be having full sentences with the person you're walking with. That's how rigorous this exercise should be. Now, risk factors that you simply cannot change include things like your personal history of cancer. A woman diagnosed with breast cancer is at a higher risk for another cancer. I've just shown you earlier today that women are just simply more likely to get breast cancer than men. The two I'd like to touch on today are breast tissue density and family history of cancer. So breast density is something that many women are not really aware of. You really won't find out what your breast density is until you've had a mammogram. Essentially, what breast density is looking at the ratio of glands to fat within the breast. So the glands, if you remember here shown in pink, are those lobules and ducts. That's where a lot of these cells are that may become cancerous. So on your right-hand side is a dense breast, so you see a lot more pink than fat. And below that diagram is what a mammogram of a dense breast would look like. On your left-hand side is a fatty breast, and then on the bottom you see what a fatty breast looks like in a mammogram. And I will tell you, in general, a woman's breast, as she ages, becomes more and more fatty, but not necessarily. The reason why this breast density issue is important is because women who have dense breasts have up to 4 times higher risk for breast cancer than a woman with fatty breasts. Reasons include that dense breasts are just harder to detect a cancer in. So if you see here on the right-hand side, you see the arrow pointing to a bright mass. That's a tumor. We won't know if it's malignant or not unless we take a sample, but for today's talk, we'll assume this is a cancer. So it's much easier to spot that bright area in a breast that is more fatty. When you look at the other mammogram, you see why it would be harder to spot that tumor. There's a lot of brightness in there. It's just hard to detect those. But we also know because there's a lot more glands in a dense breast, there's just a higher risk for developing a cancer in that breast. So moving on to family history. Family history is a question I get asked a lot about. So things that make me pause are things like when someone tells me about their first and second degree relatives having a lot of cancers. So the first degree relatives are your children, your siblings, and your parents. Second degree relatives are grandparents, uncles, and aunts. So when someone is telling me about those specific relatives and telling me about their cancer, that's when I'm starting to pay a lot of attention. So if you have a first or second degree relative that's been diagnosed with breast cancer under the age of 45, if they've had triple negative breast cancer, I am moving. Sorry, guys. Well, there you go. It's all listed for you. So triple negative breast cancer, bilateral or both breasts with cancer, ovarian cancer, and male breast cancer. So those are things I pay attention to. And you see here that I'm not just talking about breast. Things about family history that can be important are things like ovarian cancer, breast, and prostate cancer. Other things I think about is if you have family members, more than 2 family members who were diagnosed with breast cancer under the age of 50, or if I hear the words high-grade prostate cancer. These are things that make me wonder about family history. Is there something that was passed down through generations that increases that risk for that person from a genetic standpoint for cancer in general? And so before you talk to your doctor, you really want to gather some information. So we're mostly interested, again, in your first and second degree relatives, and I've listed them up there. And the questions you want to ask are, who had cancer in my family? How old were they when they were diagnosed? What kind of cancer did they have? And are they alive? So I put a picture here of Angelina Jolie. She was the first, I think, celebrity to come public about her hereditary risk. She had BRCA2, BRCA2. I think many of us have heard of this. But essentially, when someone inherits this genetic change from their parents or a parent, their risk for breast cancer goes up from that 12% for the average woman to about 80%. And even though I told you this family history and your genetic risk is something you cannot change, if you are found to have an increased risk for breast cancer, there are things we can do to help reduce your risk. So things like increased imaging. So we don't just do a mammogram for these women, we add MRIs also every 6 months. So it's a bit more imaging, but it helps us catch things a lot earlier, which is the goal of screening for these patients. We also can offer surgeries, and we can offer medications we call chemoprevention, so medications that can help reduce your risk and actually half it in some instances. That's all I had to talk to you all about. Now I'll take questions.
For those of us joining in person, if you have questions, just raise your hand and then I'll bring you the mic. I can just repeat it.
So I can hear you.
For those who are counted as hereditary, does that mean that the gene is simply passed, or does that mean that does that include those who may have had a parent who ended up passing suddenly after finding out, and they may not, is it gene related or anything like that? Like, I guess, is the gene automatic, or I don't even know how to ask my question.
Yeah, I'll try to, I think I know what you're asking. So when I talk about hereditary risk, it's actually, so each person has a copy from mom and a copy from dad. So when I hear, for example, let's say my patient comes to tell me that her mom had breast cancer in her 40s, her aunt had breast cancer, and her sister was diagnosed with breast cancer. Now I know to focus on the mom's side of the family. So there is genetic information, there are genetic changes within specific genes that increase your risk for breast cancer that is passed down from mom to daughter.
Okay, gotcha. Thank you.
Thank you.
Okay.
Yep. We're going to go to Ms. Hayes, and then we'll come this way.
Yeah, I know you and I have talked some about some of the challenges of getting families to do genetic testing. I just wanted to ask if you could maybe share with this audience what some of those issues or concerns that have been raised by family members who have been encouraged or recommended to have genetic testing.
Yeah, thank you, Lisa, for asking this question. It's something I'm really passionate about. It's just way beyond the time I can spend talking about this issue. But essentially, what becomes really important is once a person is identified to carry a genetic change, we call it a genetic mutation, that increases the risk for cancer. And usually it's a person who's already been diagnosed with cancer, so they undergo the testing based on our recommendations. What becomes really important is that that person's family members are also notified of their risk. So I'll give an example. So if a mom is found to have BRCA, for example, or BRCA2, that doesn't just mean that her risk for cancer is high, but also means that her daughter's risk is up to 80%. Her sister's risk is also up to 80%. And her daughter has a 50% chance of having had inherited that same change. So it's really important for women and men to be aware of their family history, but also if that they are found to have a genetic mutation, that they share that with their family members. And Lisa and I, we're working on a project that actually specifically looks at African American patients. Data actually showed that African American patients are just less likely to get genetic testing. There are many reasons for this, including that physicians are less likely to recommend genetic testing for patients. So that's why we're trying to raise awareness to that issue. If you think you have a family history, bring it up to your doctor. And not only that, but if you know, for example, that your relative has a genetic mutation, let your doctor know. Ask for genetic testing. Ask for to speak to a genetic counselor. Because what our data, some of the research we're working on, we actually showed that not only are African Americans less likely to obtain genetic testing or get recommended genetic testing, they're also less likely to share that information with their relatives. So that's why being aware of your family history and helping advocate for genetic testing is extremely important.
My question was, knowing what you said about how African American and other minorities have a higher risk of having those more aggressive types of cancers, has that changed the guidelines for initial mammograms age-wise, yes or no?
That's an excellent question. The answer is no. So we don't based on race or ethnicity change screening. We really use family history to determine that.
Is there coverage on insurance or commercial insurance for genetic testing?
Yes. Yes.
Medicaid?
I'm sorry?
Would it be covered on Medicaid as well?
So what I tell all my patients is I never know. They should cover this, yes. What I tell people is usually these tests do not get run unless we know that insurance will pay for it. And usually we try not to order them unless the person meets criteria. So we have certain criteria that the patient has to meet before we order the testing. Some patients choose to get the testing, even if I say, for example, I don't think your insurance will pay for it. Unless things have changed recently, the most I have seen a patient pay out of pocket has been $250. But insurance should be paying for this, absolutely. Lisa, you have a question?
Now, Not a question, but a shameless plug. In terms of paying for genetic testing, Pink Forever Ending Disparities, that is one of our initiatives. We have a assistance fund that will provide assistance with paying for not only rent, utilities, things like that for people that are in treatment, but also for family members who need genetic testing. And if there's some amount that's like a copay or something that's not covered by insurance, our assistance fund will cover that.
I'm glad you said that. Thank you.
That is not shameless at all. Thank you.
Yep. Thank you.
Did we have any other questions from the audience that's joining us in person today?
Okay.
No.
Anything online?
Last I checked, I don't believe I've seen any
Okay.
online questions. Well, again, thank you, Dr. Kasim, for giving us that wonderful presentation on breast cancer. Can we have another round of applause for that presentation? Thank you. All right, next we're going to transition into our next physician presentation over lung cancer presented by Dr. Francesca Duncan. Dr. Duncan is an assistant professor of clinical medicine at Indiana University School of Medicine with clinical training in pulmonary and critical care medicine and a passion for ensuring health equity and deciphering the social determinants of health and epigenetic factors underlying observed disparities in lung cancer, development, treatment, and associated outcomes. As a physician scientist with a translational lens, she is interested in intersectionality of biologic and socioeconomic factors in the development of lung cancer, particularly for Blacks who carry the burden of this disease. Dr. Duncan completed medical school at Meharry Medical College in Nashville, Tennessee, followed by residency training in internal medicine and pediatrics at The Ohio State University / Nationwide Children's Hospital. As a board-certified pulmonologist, she cares for patients at Eskenazi Health and Indiana University Hospital System with an array of lung diseases, including chronic obstructive pulmonary disease, also known as COPD, pulmonary hypertension, COVID-19 pneumonia, interstitial lung disease, and lung cancer. She is also involved with the lung cancer screening program at Eskenazi Health and was recently awarded the PRIME grant at Indiana University, where she and colleagues will be improving lung cancer screening through education, community outreach, and patient advocacy. As a nationally recognized speaker, she has given talks discussing lung cancer disparities locally and nationally, including at Vanderbilt University, Meharry Medical College, Cornell University School of Medicine, American College of Chest Physicians, and the American Thoracic Society. As a published medical educator, she has helped develop workshops surrounding identifying and addressing microaggressions and racism in medical education. These workshops have been presented locally and nationally and include a tool that can be adopted and implemented at other institutions to help address such issues. Serving the underserved and mentoring those underrepresented in medicine are what truly motivate her to do this important work. Please welcome me in inviting Dr. Francesca Duncan to the stage.
Okay, thank you so much, Camille, for that introduction, and thank you all for inviting me to speak. I'll say I'm trying to be very uplifting, but I actually just worked a 12-hour shift and got off at 7:30 this morning. But I think that this is so important, so I was very, very happy to be here. So mentioned, I am a lung doctor, so I study diseases of the lungs, and I think it's perfect that I'm actually following the talk about breast cancer, because I'm just curious, how many of you all are familiar with lung cancer screening in this room? Is that something that you all are aware about? Okay, so a few hands, and so I would gather a few less hands than those of you who may be aware about mammography. And I'll say one of those reasons is because lung cancer screening is very, very new, as in within the past 10 years. So lung cancer screening just came about in 2013, whereas for mammography, this has been going on since the 70s. So this is something very, very new. So if you haven't heard about it, that's okay. But when you leave here today, please tell a friend about lung cancer screening, okay? So I want to start by giving some personal disclosures. So I think anytime you are having a speaker kind of talk with you about an issue, it's important for you to understand not only are we providing you with information based on scientific fact, but we're also coming with our own experiences. And so I'm going to put these out there so that you know where I'm coming from and why this work is so important to me. So I was born and raised in Fort Valley, Georgia. I'm sure no one here has heard of that, and that's okay. It's about an hour and a half south of Atlanta. Now, I bring this up because growing up, I was not aware that I was a product of racial segregation. So how many of you all know what that is? Okay. So in my small town, one high school, one middle school, one elementary school, my mom was a teacher, so I could do absolutely nothing wrong. We lived in a city or a town in which there was a railroad track that separated the quote-unquote white side of town from the black side of town. I didn't realize that all the schools, the grocery stores, the post office, the fire station, the hospitals, all of those things were on the quote-unquote white side of town. And here on where I lived on the black side of town, I only saw neighbors that looked like me. Okay, so growing up, I would often hear stories about, well, someone in my neighborhood, they had to call 911, and the ambulance ended up taking 45 minutes to get there because there was a train on the track, and so many situations, patients would die. And so I didn't know that I was a product of this growing up, but now that I know, I now understand how health disparities and racial disparities can come about, because if you're not in a neighborhood in which there are schools, there are libraries, there's access to quality care, you are bound to have some of these diseases and conditions that we're going to be talking about today. I'm also a physician scientist, so this is someone who went to medical school, became a physician, and also, in addition to that, does research. And so one of the things I study is lung cancer. And then I'm a proud 3-time graduate of an HBCU, so I went to Tuskegee University and Meharry Medical College. So my why. Thank you. So my why. So I kind of talked a little bit about where I come from, but I didn't really realize as a medical student how impactful we can be in terms of our communities as physicians. So really going beyond the hospital. And so those are some of the things I do. So when we witnessed the death of George Floyd, myself and a few other colleagues created this white coat for Black Lives Matter. And during that time, we challenged providers to really look and see how social injustices are also impacted by systemic racism, and how systemic racism can lead to disparities within our communities. And then also, I would be remiss without saying that one of my dear close friends, Dr. Shanice Wallace, was a resident at IU, and unfortunately, Shanice lost her life 2 days after giving birth to her daughter, and that was from complications to preeclampsia, which I think we all know disproportionately affects Black women as well. So Shanice and I, studied disparities together. We're from small towns in Georgia and Alabama for her, and so I'm continuing to kind of push this work forward since she's no longer here with us. So let's talk about lung cancer. So lung cancer is the third most common cause of cancer, but despite that, it's the #1 cause of cancer death in the U.S. Now, I'll say that they give some estimates for the number of cases this year, and so approximately 238,000 new lung cancer cases will be diagnosed this year, about 117 in men and about 120 in women. And then in terms of lung cancer deaths, about 127,000 individuals will die from lung cancer this year, about 67,000 men and about 59,000 women. And I will say that in terms of these numbers for mortality or death, African American men carry the burden of lung cancer in terms of death, and African American women also carry that same burden in terms of death. So to be quite frank, every outcome as it relates to lung cancer, Black individuals are disproportionately affected by. So 1 in 16 people will be diagnosed with lung cancer in their lifetime. And I'll pause here to talk a little bit about some common symptoms. So the thing about lung cancer is your lungs are inside of your chest. So unlike breast cancer where you may see a lump, you may feel a lump, you can't feel lung cancer because your lungs are inside of your chest. But these are some common symptoms that you may have, but you'll notice that some of these symptoms are very nonspecific for cancer. So cough, shortness of breath. You may be actually coughing up blood, which is absolutely not normal under any circumstance. And if that happens, you should definitely see a doctor. You may have unexplained weight loss. You may even have shoulder, arm, or back pain, and that may be because where the tumor is located, you may have referred pain to those areas as well. And you may be someone, well, you go to the doctor multiple times, they diagnose with you with pneumonia, you're on antibiotics, and then it seems like you keep getting pneumonias repetitively. That might be something that you talk to your doctors about to get a special imaging to see if maybe you have lung cancer, especially if you're a smoker. So 2 main types of lung cancer, small cell, non-small cell. The most common type is non-small cell. And so the majority of what I'll be talking about today will be related to that. But as you can see here, there are 4 types under non-small cell, with adenocarcinoma being the most common. And when we talk about lung cancer, there is a lot of talk about smoking, because lung cancer, 80% of cases of lung cancer are associated with smoking. But that means that 20% of cases means that patients don't even have a history of actually smoking cigarettes. And so it's important to know that just because you're not a smoker, that does not mean that you are exempt from having lung cancer. If you have lungs, you can develop lung cancer. And so I think that's an important point to get across today. So the largest predictor of survival is stage, and so that's why there's a huge push towards screening. If you're diagnosed with an advanced stage, so stage 3 and 4, while there are new options, treatment options now, and in some cases stage 3 can actually be curative, the earlier you diagnose lung cancer, the better. Because if you diagnose it early when it hasn't spread, you can actually cut out or remove that particular tumor. And in those situations, we consider that to be curative surgery. And after that, you'll just have repeated CT scans to kind of monitor to see if the lung cancer comes back. And I get excited about these cases because these are the people that we see it, we biopsy it, we get it cut out, and then they come back to clinic and they're cured. So these are the cases I get excited about. So let's move through and talk about lung cancer disparities. So the term disparity, I'm going to explain that a little bit, but it actually came about in 1990. And some things that were going on at that time, the Hubble telescope went into the air. Nelson Mandela was released from prison after serving about 27 years. My favorite Christmas movie, Home Alone, came about. And then for you football fans, the San Francisco 49ers won their 2nd consecutive Super Bowl. And so disparities can be defined as a particular type of health difference that closely linked with economic, social, or environmental disadvantage. So you take 2 people with similar male, female, similar gender, and you can see differences in terms of incidence and outcomes based on maybe being socially or economically disadvantaged. So some other definitions here, and I think it's important that disparities are actually preventable. So this is something that we can do something about. And the increased presence and severity of certain diseases, poor health outcomes, and greater difficulty in obtaining health care services for these racial and ethnic groups. And disparities are related to inequities in education, poverty, access, and so those were some of the features that I mentioned in terms of the environment or town that I grew up in. And they are driven by these underlying social and economic inequities that are rooted in systemic racism. So many of us that do work in disparities are very familiar with these two pictures. And so on the left here, there's a picture here or an imagery of equality. So equality is, you can see these three individuals trying to see into this baseball field, but the gentleman here in the purple shirt, even though they're all given the same resources, he still can't see into that baseball field or still doesn't have access to good care. And so that's what equality is. Now, equity should be the goal, because with equity, you are giving people resources based on what they need. And so a lot of times people feel like, well, this is giving certain people more resources, but you're actually trying to kind of level the playing field so that everyone has access to quality care. So in terms of lung cancer disparities, I mentioned a few. So we know that blacks have a higher incidence and mortality rate of lung cancer compared to all other U.S. racial groups. And doesn't that sound very familiar in terms of what we just heard about breast cancer? We also know, as I mentioned, that African American men have a higher incidence and death rates of lung cancer compared to any other racial group. And then the same can be found in terms of African American women. And I mentioned that stage is so important. In addition, when blacks are diagnosed with lung cancer, they're more likely to be diagnosed with advanced disease, and that's for several reasons. As I mentioned, you can't feel lung cancer, so sometimes by the time you are coughing up blood, it may be too late. And so that's why screening is so very important. And that's what some of the work that I do in terms of trying to reduce lung cancer risk by screening and early detection. So I have good news, and that is that mortality rates in terms of lung cancer is getting better, so that is decreasing. And this is mainly due to early detection with screening and also advancements that have been made with treatment. Now, the not so good news is even though we're making advancements in terms of mortality, black individuals are still having higher rates of mortality when it relates to lung cancer. Now, I asked the question when I began in terms of how many of you all are aware about lung cancer screening. And so this was a large study that was done in 2011 in which they compared a special CT scan, which in the top right, you can see that's how the CT scan is done. You kind of pass through this donut hole, and they take a picture, versus an X-ray, which I think many of us are very familiar with, where they actually shoot the picture from the front, and you can get an image like the one here on the bottom right. So they compared these two modalities and found that screening with the CT actually reduced lung cancer death by 20%. And to be quite frank, lung cancer screening with the low-dose CT is the only screening test that we have thus far that has been shown to reduce all-cause mortality. So not just reducing lung cancer, but also death from any cause. And that's because when you're getting an image of your chest, of your lungs, you're also seeing your heart. So many times we can identify enlarged hearts, calcified vessels, and so that's another thing that can be beneficial in terms of lung cancer screening. Now, problems that I had with the study, and not just me, others have had as well, is that their study included about 53,000 people, but you can see here the genetic and ethnic makeup of the people that were included really wasn't that much. And then for black individuals that carry the burden of disease, there were only about 4.5% black individuals in the study. So it's hard to say if whether or not the guidelines would actually be applicable to black individuals because they don't have enough black individuals in the study. But that's another topic for another day. You have to bring me back for that one. And so I'm putting this up here, but based on the study, they came up with these guidelines. Now, don't focus on them too much because these guidelines just changed in 2021. And the reason for that is because there was another study that actually said, hey, one of the things that the prior study did not take into account is that black individuals do not smoke the same as white individuals. So this study actually included majority black individuals and found that when black individuals smoke, blacks are more often to start smoking at a younger age. They're also more likely to kind of have these patterns in which they may not even smoke more than 10 cigarettes a day. They may smoke 4 cigarettes now. There may be a stressful situation, and then they smoke for 6 months, quit for 5 years, pick it back up for 2 years, and because of those gaps in their smoking patterns, they were not meeting the prior criteria because they didn't have that increased pack years of smoking, so they were being missed. Well, this study took that into account and found that racial minorities, so people of color, were more likely to be light smokers, so smoking less than 10 cigarettes. We also found that black individuals who maybe smoke even less than white individuals still have a higher risk despite smoking less in terms of developing lung cancer. And so for the same quantity of cigarettes smoked per day, black smokers remain at a higher risk of developing lung cancer. So this stigma that, you know, in order to get lung cancer, you got to smoke a pack a day for 30 years, it's just absolutely not true. I can't tell you how many patients I see that come in and they say, well, I only smoke 10 cigarettes or I only smoke 7 cigarettes and still develop lung cancer. So that's very important to note. So if I can give you any information to take home today is when it comes to lung cancer screening, if you are between the ages of 50 to 80 and you are a current smoker or quit smoking within the past 15 years and you have a 20-pack year smoking history, then you're eligible for lung cancer screening. And the calculating the pack year part is kind of tricky. But essentially, you ask yourself, how many cigarettes do you smoke a day? There are about 20 cigarettes in a pack. And so what you would do is you would multiply the number of packs you smoke a day, on average, by the total number of years you've smoked, and that gives you your pack years. So if you meet those 3 criteria, you qualify for lung cancer screening. And good news with that is that lung cancer screening is covered by all insurances, and including Medicare and Medicaid. The I guess tricky point there is while it's covered, you may have to go to different places to get it based on your insurance. So the good thing about screening that it's done with the low dose CT, so it has less radiation than a regular CT. And with the low dose CT, it's a very quick test. You just go through the scanner. It's also painless. And so there's really nothing you have to prepare. There's no special IV, no special dye for the test. But the reason that you should get screened is because lung cancer screening actually saves lives. And if we find the cancer earlier, it can be treated and potentially curative. So I mentioned to you all the 3 points in terms of who should be screened and how to calculate your cigarette smoke. And I want to focus here lastly on the lung cancer screening programs that exist at both IU Health and also at Eskenazi Health. And so these are 2 hospitals that I work in, and at Eskenazi Health, I'm directly involved in the lung cancer screening program. So I do have a few cards, so if you're interested in trying to get plugged into that, please let me know, and I'll be happy to give you a card to get you in and scheduled. But the benefits of these programs is that if you are referred by your primary care doctor to this program, you will actually have your CT scan reviewed by lung doctors like myself, radiologists, surgeons. We meet once a month and we look at everyone's scans and we say, based on the guidelines, what should be the next step? If we look at it and there's no concern there, we tell the patient, just come back in a year. Because that's the key about lung cancer screening is that you have to keep coming back each year for the CT scan in order for us to actually see the benefit in terms of reducing cancer. And then also you have a dedicated nurse coordinator that will give you a call and let you know what to do next and also remind you to come back in a year. And lastly, in the program, we provide tobacco cessation treatment, whether that be medication, but also some helpful racially, cultural, behavioral modifications to try to help in terms of quitting smoking, because we know that quitting smoking, it's a little bit different for different racial and ethnic groups, so we have that available as well. And a question I get all the time is, how long should you be screened? So once a year until you either age out, so you're over 80, and until you develop a health situation in which your risk for death from that far exceeds the risk from dying from lung cancer. Or if you absolutely say, well, if you find cancer, I don't want the surgery, then you don't need to be screened, because one of the caveats is that if we find it early and the treatment would be surgery, then that's what we're going to recommend. Although there are alternatives to surgery now, and that sometimes can be something called stereotactic radiation, where they actually just radiate the spot where the cancer is in hopes that it will shrink and cure the cancer. And then I get this last question a lot too. If I don't qualify for screening based on those 3 criteria, what do I do? Well, I will say that we're currently continuing to do research about this, so the guidelines may change again as we start seeing what are the best criteria to identify those that are highest risk. But things you can do is, if you're a smoker, talk to your doctor about help in terms of quitting smoking. And then limit your exposure to secondhand smoke, because secondhand smoke increases your risk of developing lung cancer by 20%. So if you can imagine even a child in the home of 1 or 2 parents that are smoking, and they are in that home for the duration of their childhood, then their risk for developing lung cancer is greater just by being exposed to secondhand smoke. And then also one thing to consider, the second most common link to lung cancer other than smoking is radon. So this is one of the things that we may not be aware of, but you can actually get your home or your basement tested for radon to see what are the radon levels, and if they're high, you can then get treated. That is all I have for you. If you have any questions, please let me know. I'll be happy to answer those.
Thank you. Does anyone have any questions for Dr. Duncan?
So I'm just considering the guidelines. I know the American Cancer Society is currently reviewing their guidelines.
Absolutely.
And then I'm thinking about like that secondhand smoke exposure. So I have a child who grew up in a home with 2 smokers, not me, grandparents. The grandfather actually passed away from lung cancer, but he's never smoked, but sometimes I feel like I could hear it in his chest that he grew up in a home with smokers. But the guidelines don't really consider that when it comes to screening. Do you feel it should, or do some changes there? Do we need
Yeah,
to
so that's a good question. And to be honest with you, right now, secondhand smoke exposure is not recommended, but as I mentioned, the guidelines are probably going to be changing, because even merely having COPD can increase your risk for developing lung cancer, and that's not in the screening guidelines. So these particular studies are being done constantly. One of the studies that I'm looking at Eskenazi is also looking at other risk factors. And so I think even there may be something, we're also developing what we call risk calculators, which honestly look outside of clinical characteristics and are looking at other factors like insurance status, distance from a hospital, because we know that those are also things that increase your risk. And so to be honest, right now, a lot of those risk calculators are finding that taking into consideration insurance status and access to care may be even more beneficial when it comes to identifying those at high risk for lung cancer than even some of the current things in the guidelines for now. So these guidelines are in order for the insurance company to pay for the testing. But if you are someone that says, hey, I want to go ahead and pay for the testing, the CT scan at IU is about $200 if you're paying out of pocket, not with your insurance. So if you're someone that's like, hey, I've been exposed to a lot of secondhand smoke, and I really want to know, you can get it outside of the guidelines, but you have to pay out of pocket because the insurance companies are only covering it if you qualify based on those 3 things.
Does Eskenazi or IU have programs to help offset that cost, especially for underserved, under-resourced communities?
Yes, so that's a good question. So right now we do not. I wanted to be able to say, hey, these are some places you can go get free lung cancer screening, but because it's so new compared to breast cancer, we don't have like resources and things like that for lung cancer screening. But as a researcher, I'm constantly writing grants, trying to find money to be able to do those types of things for our communities.
I'm going to go ahead and do a plug real quick. In Lung Cancer Now is also here with us in the back if you want to, wave. They also have resources and can point you in the right direction for some of those questions that you have. Do we have any more questions in person for Dr. Duncan?
Thank you.
All right, well, thank you. Thank you again, Dr. Duncan, for such an engaging presentation. Next, we're going to move into our last part of session 1 with our colorectal physician presentation presented by Dr. Thomas Imperiale. Dr. Thomas Imperiale is the Lawrence Lumig Professor of Gastroenterology and Hepatology at the Indiana University School of Medicine. Dr. Imperiale joined the IU faculty in 1996 as a collaborative and independent investigator in both gastroenterology and health services research at the Richard L. Rodebush VA Medical Center. His research is based broadly on technology assessment of diagnostics and therapeutics for digestive and liver diseases, applying different study designs and quantitative methods to luminal, hepatic, and pancreatobiliary disorders. As a K-24 awardee from the National Institute of Diabetes and Digestive and Kidney Diseases, Dr. Imperiale has mentored dozens of junior faculty and fellows. His independent work has been focused on screening and surveillance of colorectal cancer and includes tailoring screening and surveillance based on individual patient risk. He has approximately 160 peer-reviewed publications, including several in journals such as the Annals of Internal Medicine, New England Journal of Medicine, JAMA, Archives of Internal Medicine, and Gastroenterology. Dr. Imperiale has held leadership positions within research for the American Gastroenterological Association, American Society of Gastrointestinal Endoscopy, and VA's Health Medicine. He was a member of the editorial board for Annals of Internal Medicine and is an elected member of the Association of American Physicians. He has obtained more than 40 research grants, including several from federal sources, NIH and VA, and professional societies. Please welcome me in joining Dr. Imperiale to the podium.
Thank you, Camille, for that introduction, and good morning. I'm going to mostly be turned this way since I don't have slides with me, but they're up there. So we're going to talk about colorectal cancer. So let's start with knowing where the colon is. And in short, are you able to hear me okay? The esophagus gets nutrition to the stomach breaks it down, the small bowel processes it and absorbs it, and the colon takes care of the waste, okay? And eventually you eliminate that. So this organ up here is the colon, and you can see it's quite long, fully expanded, it's about 6 feet. The small intestine is sort of inside of it, and then when the small intestine is finished processing food, it enters the colon, and eventually that's eliminated as waste material. So colon cancer is, we can expect in the year 2023, 150,000 new cases and 55,000 deaths, okay? And this is despite organized screening since 1996.
So the first speaker talked about breast cancer screening being around since the 1970s, and Dr. Duncan mentioned lung cancer screening around since about 10 years ago. Colon cancer broke in late in the 1990s and is sort of in between those two cancers as far as screening experience. It's the third most common cancer in men and women separately. Lung is first in both, breast is second in women, prostate is second in men, and then colorectal is third in both. When you combine men and women, it's number 2, and when you consider non-smokers, it's number 1. The good news is that colon cancer incidence and mortality is falling in the U.S. in people over age 50. There are 2 exceptions. Ages 29 to 49, where we're seeing cancer rise in those age groups. Etiology not really clear. Inactivity and weight may have something to do with it. And then there are certain hot spots. And Indiana abuts one of those hot spots in the southeastern portion of the state, where people, especially under age 50, are seeing an increase in colon cancer screening. The reason is that they're not getting screened. And this is a slide of the U.S., and the red areas or the maroon areas have the highest incidence. The beige areas are second highest, and you can see Indiana, Ohio, and Illinois are in that category. And you can see that the states in blue have the lowest death rates for colorectal cancer. So there's work to do in this area of the country, and particularly in the South. You see Louisiana, Mississippi, Alabama. There's a lot that needs to happen in those states to bring the cancer mortality down. So I think the top part of the slides aren't coming in, but it's not a big deal. If you can make a minor adjustment, that would be great. There are risk factors for colon cancer, and there are factors that protect people against it. Older age is a powerful risk factor for colon cancer. Being a man increases the risk at any age group by about 40%. And that's true for both colon cancer and the precancerous polyps that are most likely to progress to colon cancer. Cigarette smoking. So not only does it increase your risk for lung cancer and breast cancer, but colorectal as well. Increased weight, the body mass index. The body mass index is the weight in kilograms divided by the height in meters. And it's a little bit awkward to calculate, but a normal BMI is somewhere between 20 and 26 kilograms per meter squared. You just remember the number. Once you get over 30, the risk starts to go up of colorectal cancer. So certain alcohol, so 3 or more drinks per week are felt to be associated with increased risk of colon cancer. Certain elements of the diet, especially red meat, more than 5 servings a week of red meat starts to increase risk. Having a family history, and the FDR on the slide stands for first degree relative. So if you have a first degree relative with colon cancer, what is next important to know is what age they developed the cancer. If they're under age 60, that is a powerful risk factor for that first degree relative and its effect on you. If it's over age 60, it's still a risk factor, but not as powerful. And if it's not a first degree relative, then the risk is really small, like if it's a grandparent or a cousin. It doesn't increase your risk all that much unless there's also a first degree relative with colon cancer. And last, sedentary lifestyle. Everybody's getting more sedentary because of technology. We have to fight that because it increases risk being inactive for colon cancer. There are also factors that protect. So physical activity protects. Certain elements of the diet are protective, fruits and mostly vegetables. A previous negative screening test is a very powerful predictor, especially if that test is colonoscopy. Taking aspirin or NSAIDs on a regular basis, not something you want to do just to prevent colon cancer, But if you happen to be taking them for other reasons, like for cardiac causes or for inflammatory causes like rheumatoid arthritis, you can derive protection from that. Still not enough to avoid screening, however. And then hormone replacement therapy, estrogen replacement for women who are postmenopausal. There are signs and symptoms of colon cancer. We don't like to make the diagnosis like this, but we unfortunately are still making most of the diagnosis because people are presenting with signs and symptoms. And they include rectal bleeding, so any blood per rectum, unless it's blood only on the toilet paper, only with straining, and it's been going on for a while, meaning years and years, on and off. Otherwise, if there's blood on the toilet paper, that is a symptom, a sign of colon cancer. It could be something else, though. A change in bowel habit. So lots of people will add probiotics to their diet or change their diet. This change is more significant. It's a change in the color or the frequency or the consistency of the stool that's not related to medications or diet. It's a tough call to make. The bottom line is if you notice a change in stool caliber or in bowel habits that lasts for a while, meaning a month or two, that's something to report to your doctor. Lower abdominal pain. Again, there's lots of reasons for lower abdominal pain. Colon cancer is just one of them, but if that pain is persistent, especially if it's associated with other symptoms like weight loss or change in bowel habit or anemia, that's certainly of concern for colon cancer and needs to be checked out. And then the less specific symptoms are fatigue and listlessness. Do you know anybody who's not a little fatigued? So again, it's very nonspecific, but when you put them together, that can be an early sign. And then there are signs, in other words, more objective things that we find when we evaluate patients. Anemia is one of them, especially iron deficiency anemia, and especially in a man or a woman who's postmenopausal, is concerning for colorectal cancer. And then unintentional weight loss. So people who say, oh, I wish I could lose weight, without trying, this is not a good thing. And it could indicate that there's a cancer somewhere. The GI tract is in that list of possible sources. So how do we diagnose it? Well, we investigate people with signs and symptoms. We do workups with CT scans, colonoscopy, sometimes surgery. We don't really like to have to find it surgically, but we do sometimes. And the reason we don't like it is because it's often advanced, and there's much less that can be done in advanced stages. So early diagnosis, important for breast and lung cancer, also important for colorectal. And then we screen people. So what is screening? When we say screening, what are we talking about? We're talking about testing people who are asymptomatic. So they feel well. They don't have any signs or symptoms. And this is one of the challenges with the screening process. It's getting people who are healthy or who think they're healthy to submit for testing. In colorectal cancer, up until just 3 or 4 years ago, the age to start screening was 50. In blacks, it was 45 because of increased risk. And we'll talk about that increased risk shortly. But 3 years ago, actually 4 years ago now, the American Cancer Society said we have to lower the screening age range. They were bold to take that step. Some people felt like they were being overly aggressive, but the data support that the risk in 50-year-olds in the 1990s is the current risk in 45-year-olds now. So 45 is the new 50. That's not good when it comes to cancer. This is why the recommendations now say start at age 45 for average risk. And I'm going to focus mostly on average risk for the rest of the talk. If you have a first-degree relative with colon cancer, it depends on their age, as I mentioned earlier. If they were diagnosed under age 60, then the recommendations are to start at age 40 or 10 years younger than that first-degree relative. So if that first-degree relative developed colon cancer at the age of 45, that means you, as their relative, have to start screening at age 35 and with colonoscopy because it's so high risk that we couldn't count on a non-invasive test to miss a diagnosis. So what are the options for screening? There's lots of options, and actually this is a problem, because giving people too many choices can sometimes cause them not to make a choice. There are invasive options, colonoscopy, which is recommended every 10 years. I'll say more about that in a moment. Sigmoidoscopy, the short scope that looks at the left side of the colon, is recommended every 5 to 10 years. There are stool-based tests, and the fecal immunochemical test, or FIT test, is foremost among them. That's recommended once a year. And then also there's the multi-target stool DNA test that looks at mutations in the cells that line the colon, as well as bleeding that comes from the colon. That test is recommended every 3 years, okay? You may have seen the commercials for the test Cologuard on TV. That's the combination FIT and DNA test. And then there's radiographic testing. CT colonography, also known as virtual colonoscopy, is recommended every 5 years. And then there's a blood test, which is currently not recommended in guidelines, but it is available. It is not covered by insurance, and so we don't really recommend it. It's not really a good test, but it is out there for people who absolutely don't want to be screened by any other method and are willing to pay for it. So here's the fecal immunochemical test. It's a tube with a cap on it. There's a brush in the tube. There's other apparatus that comes with it, an envelope for return mailing. You have to put this paper sling, across the toilet seat. You basically have to poop in the sling, and then you take out the brush and you brush the stool in several different places and put it back in the tube and seal it and mail it, okay? And it will come back to your doctor. You can get these online. I don't recommend it. The quality control for these is not known, and the cost is significantly more than your healthcare system or you would pay. This will be covered under current healthcare. This is a covered service. This test gets done annually. Pros and cons. It's non-invasive. It can find colon cancer about 3/4 of the time, meaning that it'll miss it 1 out of 4 times. And it can also find the worrisome of the polyps, precancerous polyps, but it's going to miss them some of the time. So that's the reason for the repeat application. If it's negative 1 year, it may turn positive next year. The polyps don't progress all that quickly. Polyps sit in the colon for years and years before they turn to colon cancer. That's the thinking. So you have time to pick them up if you do the FIT test every year. It's convenient and it can be done at home. There's no diet restrictions and there's no need for bowel prep. The downsides are that it's not a perfect test. It can miss cancers and it can miss polyps. It has to be done every year, so it requires a diligent person or a diligent healthcare system or both to make sure that people who are negative 1 year get retested the next. And then also, if the test is positive, you need a colonoscopy. The last thing is that some people get a little squeamish when they have to put the sling in the toilet, collect the specimen itself. They don't want to do it. So those are the downsides of the test. There are a number of FITs available in the United States. The most common ones used in healthcare settings are at the bottom of the slide, the OC Lite and the FIT FOBT check. One of them is manual, meaning it's developed manually in the lab. The other is done automated in the lab and tested in batch form. So these are photos of what a CT colonography looks like. So virtual colonoscopy is the name it's given because the 3D view, which is pictured here and here, basically recreates what the colon looks like on X-ray. Okay, so it's kind of a cool concept. The problem with it is that it's not reimbursed everywhere. It's covered by insurance in certain areas of the country, such as North Carolina and Wisconsin. We don't have broad enough coverage for this test to recommend it, but it is available. And you can see that it can pick up, as the displacement here shows, this colon cancer that was seen on colonoscopy. You see it in the 2D view here, the 3D view here, and the endoscopic view right here. So it's a good test. You can find polyps in cancer. The downsides, it's not reimbursed. An advantage is that it can find other lesions in the abdominal cavity, like aneurysms, other cancers. The bad news is that it can find other things outside the colon in the abdomen, like that make people worry and lead to further testing without any benefit. So cysts in the liver and kidney, maybe a small nodule in the adrenal gland that may require workup and may be totally benign. So there's downsides to having these other lesions found, okay? But this is a viable test. You do have to prep for it, and if there's something abnormal on it, you need colonoscopy. So all these other tests funnel to colonoscopy. Here's what the multi-target stool DNA test looks like. You get this box mailed to your home. There's a container. There's a sort of brace for the toilet seat. And you literally poop in the bucket. You then take a small specimen, so it's part of it is the FIT test. It's FIT and DNA. And here's the card for the FIT test. You add a buffer to preserve the specimen, and you mail it back to the company that develops it, okay? So it's a little bit more sensitive than the FIT test alone. It's non-invasive. It'll find nearly all colon cancers. More than 9 out of 10 will be detected this way. You can do it at home, no special diet required, no bowel prep, and if it's negative, you're good for 3 years, okay? The downsides, again, it's not as sensitive for colonoscopy for detecting polyps. It detects between 3 and 4 out of 10 of the most significant polyps that are important to detect, okay? You have to collect the specimen. Some people just don't want to do this, okay? If it's positive, again, you need colonoscopy. And at older ages, the false positive risk starts to go up. So once you're in your 60s, there's a 1 in 5 chance that you'd have a positive test, but then when you go get that colonoscopy, nothing's found. That makes everybody worry. Did the colonoscopy miss something? Could there be a cancer somewhere else? So there are downsides to getting tested with this technology at older ages. And it's costly. Insurance covers it most of the time. There still may be a copay depending on what your plan is, but the cost is $600. It's almost as much as a colonoscopy. So sigmoidoscopy, not much is said about this anymore. When the recommendations initially broke in, it was for sigmoidoscopy and for the stool blood test, and this test was recommended every 5 years. And it's a short scope. I show it over here under colonoscopy, but it only goes up and looks at the left colon. Most of the time, what's on the left side is reflective of what is deeper in the colon. And it can pick up polyps and cancer in this distribution, especially in people under 50, where 3 out of 4 cancers are in this distribution, okay? So the short scope does have some advantages to it. The downsides are that you have to have a bowel prep, not as vigorous as the one for colonoscopy. It can be uncomfortable. We tend to give conscious sedation for it now. We were doing it in the 90s. We weren't doing that. Some people would call that barbaric. It examines only the left colon, and these days there are issues around reimbursement and around quality and training because everybody has sort of migrated to doing colonoscopy. So what about colonoscopy? You'll notice the scope's a lot longer than the sigmoidoscope. So it examines the entire colon. If you have to have one test one time, this is the test to have, okay? Because it is basically the most sensitive test, and it's considered one-stop shopping. It's diagnostic, and it can be therapeutic by removing large polyps. It can't remove cancers, except maybe occasionally when they exist in polyps, but the endoscopist can mark where the cancer is so that a surgeon knows exactly where to go to take it out. And it affords the longest interval in screening. It's every 10 years. So if you have no polyps and you got what's called a clean colon, you're good for a decade, and it's very likely that that interval will expand and will go beyond 10 years. And it's cost effective. The downsides are that you need a bowel prep, and people will uniformly say it's the worst part of the whole thing. You also have to take time off from work. You have to arrange to bring a driver unless you want to do it without sedation, which I don't recommend, but it is doable. What about barriers to screening? There are a lot of these. Access to health care is probably the largest barrier. The second is that doctors don't bring it up. So you as patients, as consumers of health care, have to go in ready to discuss it. You have to tell your doctor, talk to me about screening. Which test do you think is best for me? There's also the fear factor, finding a cancer. The fear of getting tested. People these days equate getting screened with having a colonoscopy. That is not correct. Colonoscopy is part of screening. It's not all of screening. Most countries outside of the U.S. do not screen their population with colonoscopy. They use the FIT test, okay? We know from studying this that when you give people a choice, colonoscopy or FIT, they're more likely to get screened, okay? And this is results of a clinical trial that was done on the West Coast where they randomized almost 1,000 average risk people, and they said to their doctors, we want you to tell your patients about colonoscopy, and then to another group of doctors, they said, we want you to tell your patients about the FIT test, and then to a third group, they said, we want you to give your patients a choice. And lo and behold, within 12 months of doing that, you can see that colonoscopy was about 38% uptake. The FIT test, so the stool blood test, here it's FOBT, nearly 60%, but giving people a choice was close to 70%. So this was 67, I think my eyesight's going, and this was almost 70%. And you see that most of that difference was because of the availability of an option to colonoscopy. So we talk about colon cancer risk, and everybody knows that the risk is higher in blacks. Why is that? There's lots of reasons for it. Social reasons, access to health care, yes, this is some of it. This may be a lot of it. Uptake of screening, yes, this is some of it as well, okay? Response to symptoms, maybe. We're not sure about this, but people respond to symptoms differently. You know, men tend to deny the symptoms. Blood on the stool or in the toilet must be my hemorrhoids, okay? Lots of people want to deny those symptoms and don't want them to get checked out. Environment, so-called nurture. What factors around you or your health habits might affect your risk, such as are there less healthy behaviors among blacks? This is some of it, and this goes back to some of the social determinants of health that were mentioned earlier. And what about biology? Is there any proof that being black alone increases your risk for colon cancer? And the answer is no. In fact, there's evidence to suggest that it's not the case. And one of these is that when you look at people getting screened, so people who are asymptomatic coming in to get checked out, the risk of colon cancer and advanced polyps is the same in blacks and whites, okay? I love this study because, in my opinion, it is the strongest endorsement of screening people for colon cancer. The study was published now it's 10 years, and it tells a story about what went on in the state of Delaware, what they found when they looked at colon cancer risk and who was getting screened and who wasn't, and most impressively, what they did about it and what happened when they did it. So this is where the governor of Delaware in early 2000 said, we have a problem. Okay, there's a big gap between blacks and whites with screening. And there's also a gap in what we're finding, who's showing up with cancer and what stage they're in. So this pie chart on the left in 2001 showed that among African Americans in Delaware, more than half of them had disease that had spread beyond the colon, right? Actually, 3/4 of them, a quarter of them had metastases. Only 15% had curable disease, okay? By 2009, 50% had curable disease, and the proportion who had metastatic disease, in other words, like not curable, had shrunk to 7%. So, like, what did they do? They committed resources to screening, to identifying people at risk and getting them screened. So here you see a plot of the number of new cases per 100,000 people over these intervals of time, and they did 3-year rolling averages to get more precision. And you can see that the yellow line is the risk in African Americans, and you can see that by 2009, it had fallen. So getting people screened got the incidence down. No surprise. What effect did it have on mortality? Pretty much the same effect. These data they don't quite go to 2009, but subsequent analyses have shown that the risks are equal. When you screen people, they respond the same to screening. If they get screened and they get the follow-up testing they need, you can eliminate disparities in incidence and mortality. So in 2001, actually the screening rates were bad, independent. We're supposed to be at 80%. No one's at 80%. We're trying to get there. Whoever had screening colonoscopy, 48% in blacks, 58% in whites. By 2009, this number had come up in both, okay, and more so in blacks than whites. The incidence, which was higher in blacks than whites in 2001, was now equal, and the mortality that showed a big disparity in 2001 was now equal. I love this example. It shows what communities can do. So the question I get asked is, which test is best? And the answer is, we don't know, okay? And we don't know so badly that there are 3 trials going on worldwide comparing the FIT test once a year to colonoscopy every 10 years. And we think the results are going to show either a difference between the two or no difference between the two. And we don't know which is going to be better. The uptake of the FIT test has been better in all the studies. More people are willing to get tested up front with FIT than they are to have colonoscopy. Okay, but over time, we don't know how this is going to fall out. We expect to have answers in 3 to 5 years on all 3 of these trials. There is one in the US, and the VA is sponsoring that. Our VA is a site for it. There's one in Spain, and there's one in the Nordic countries going on right now. Some of what people should look at is their risk for, I say, advanced neoplasia. That's the combination of colon cancer and advanced polyps. And if you have risk factors, then you ought to think about getting the invasive test, going for the colonoscopy. Also, people have risk factors for not adhering to medical care. And we all know about that within ourselves. And the question is, can doctors tell for their patients who's going to be at risk not to stick with the program? In other words, they have a negative FIT test and they're done. They're not coming in next year or the year after that. So it requires consideration of a personal risk as well as what their likelihood is of adhering to, to a screening program. So for people who are high risk for advanced neoplasia, who are also high risk for non-adherence, they ought to just get the colonoscopy and get it done. For people who are not high risk and who show up for their doctor's appointments, then maybe getting a FIT test every year is a suitable option. So here's another way of looking at it. If you're high risk for cancer or advanced neoplasms and your adherence, your ability to stick with a screening program is low, then colonoscopy would be your best test. Picking one of these other ones, if you're average or high risk and adherence, you might adhere or you might not, but let's say you strongly are against doing the prep and getting sedated. Some people have a fear of getting put to sleep. They think they're not going to wake up. That never happens. Then having a flex sig without sedation, with or without a fit test, or getting the multi-target stool DNA test might be the way to go, knowing that if these tests are positive, you'd still need a colonoscopy. So the take-home points. Screening for colon cancer should start at age 45 for most people. There are choices for getting screened, okay? It's not all about colonoscopy. There are options. A FIT test every year, the multi-target stool DNA test every 3 years, or colonoscopy every 10 are the 3 most prevalently used tests for screening right now. Discuss screening with your doctor or provider. Come in ready to do it. Everybody knows, I think it's a very lame excuse that the doctors only have 15 minutes for a visit. We should be fighting for more time with our patients, even if that means we have to unionize and fight for the time. And I never thought I'd say that in my years of doctoring. And the last thing, right now, the best test for colon cancer screening is the one that gets done. Thanks for your attention, and I'll take your questions.
Should the colonoscopy, should it be younger than 45? Because we are seeing numbers for folks who are younger that are getting colon cancer. So should it still stay at 45 for the initial test, or should it drop down a little?
Yeah, it's a great question. So 50% of the risk under 50 occurs in the 45 to 49-year-old group. And the question is, should people younger than 45 be screened? And the answer is yes, and we have to figure out who that is. We are working on some studies that identify people at risk. We've actually finished one at the VA, and that paper is under review right now, where there's a risk calculator, and at least this study, mostly men being at the VA, we're able to identify a high-risk group who should get screened before the age of 45. Good question. And there are certainly people with high-risk family histories who should be screened before 45.
One of the factors you listed in looking at risk for colon cancer was BMI. And I know Dr. Kassim also talked about weight as a risk factor for breast cancer. But I've been reading in recent years about how calculating BMI is not necessarily a good measure of the weight, just because the weight is calculated in different body shapes, and particularly how it's applied to black bodies. So do you have a response to that?
Yeah, I do. That's a great point. BMI is probably not the best metric, but it's the one that is most easily calculated. In my own studies, what I've found, and when I've looked at body habitus, is that the waist to hip ratio is a better indicator. But most people, most people don't know those measurements and may not want them put in their medical record, if you know what I mean. It's hard enough to get people to step on a scale now, right? And doesn't it always seem that the scales are in the lobbies or in the waiting areas, right? Right. So this information needs to be obtained. Waist to hip ratio is a better measure, and even waist circumference alone is a better measure, and this is an area of active research.
So I have a question. Well, actually, question / statement. You mentioned what's the best test, and they're doing studies. Can you hear me?
Now I can, yes.
Okay. You mentioned about the studies trying to determine what is the best test. And I guess I always think back to, isn't the best test the test that a patient is willing to do? But then also with this study, so with the FIT test, you have to go back every year. Are you studying if they're adhering to that? So, for example, if there's a person in your study, are you ensuring that they're going back and repeating the FIT test on an annual basis? Because then would it be slightly flawed to say the FIT test isn't a good test if they aren't adhering to the annual guidelines?
Yep, that's a great point. It has been studied, and unfortunately, the adherence to repeat testing falls off. After 2 years, it really starts to fall off. And the test really doesn't gain its power until you put together several negative fit tests. So once, having one negative fit test is like, it's better than having a positive fit test, but you don't start to gain the power from that strategy until you've done repeat testing. Okay, so, and adherence to it over time is a problem. It's not just a problem for patients, it's a problem for healthcare systems. Lots of them do a poor job of keeping track of that, and they'll go nameless, but there are some here in town. They need to do a better job. And they know it, because I've told them. Any other questions?
Yes, I have a question.
Yes.
So we know that smoking cigarettes is a risk factor, but there are a lot of options for nicotine that aren't cigarettes. It could be the loose tobacco or the vaping, and with young people starting to vape so early, as teenagers, do we have any data that talks about those other forms of nicotine as a risk for colon cancer?
So for colon cancer, there are no data about that, about these other forms, because they haven't been around long enough, and also the age group exposed to them is very low risk for colon cancer. I am sure that the ongoing studies that are looking at risk factors in young people are considering cigarette smoking and alternative mechanisms for using nicotine. All right, and anything beyond that, I defer to Dr. Duncan.
So it may be a few years before we know.
Yes, yes, it is. But I know in studies that are looking at risk factors for people under age 50, that is on their agenda as possible risk factors. Cigarette smoking is probably contributing something, but most of the studies on cigarette smoking show that it needs a lead time. It needs 20 years. So smoking in your 20s may be related to risk in your 40s. There's a lag. And likewise, there's a lag after you stop cigarette smoking before cancer risk falls and before heart disease falls.
You talked about the non-adherence to testing, and at the health clinic that I serve with, that's a big thing. People just, they don't want to. They don't want to know, they don't want to think, they don't want to do. So hearing the things you're talking about, are there tests that we can recommend that would show a general elevated risk for all sorts of cancers, or is it everything specific? Because I know we have a lot of patients, and then how do you counsel with other healthcare providers as to what their biggest risk is if we're only sending them for one test?
Yeah. Wow. Do I wish I had an answer for that? There are multi-cancer early detection tests in development right now, where a blood test is being designed to pick up multiple cancers, some that we screen for because we know we should be, others that we screen for because we don't think we should be. And this is a very active area of research right now. There are several in development, and I will tell you, my knowledge of this is limited. The first speaker may have more knowledge about this. But in general, the colorectal cancer screening tests still do a better job of picking up colorectal cancer, as you'd expect, because by the time a blood test turns positive, usually it means that the cancer is invasive. That's not what we're looking for. We're looking to get it before it becomes invasive. And I'm not sure about how well these blood tests are picking up other cancers that we screen for. My thinking and my recollection is that mammography is still better for breast cancer, pap smears is still better for cervical cancer, and lung cancer screening is still better for lung cancer than these blood tests. With the blood tests, you get what you pay for. And we're going to be paying a lot for them. And that's why we have to demand a very high level of performance. And we're not there yet. So the answer is, unfortunately, no. It's taking your patients through it, educating them, and trying to convince them to have a test at some point.
Doctor, I have a question over here on this side.
Yes.
For those who may be experiencing rectal bleeding, and it may lead to like diverticulitis or those other illnesses, what is the threshold to know if it is something as extreme as colorectal cancer, or things like what is that line that kind of differentiates what irritable bowel or those types of things are as opposed to cancer?
That's a good question. So irritable bowel, you don't make that diagnosis in the presence of rectal bleeding. You can't do it until you know why the bleeding's occurring, okay? So it used to be, when I started doing this, that if a young person came in with rectal bleeding, we would maybe evaluate them and do a rectal exam. If they had hemorrhoids, we might say it's probably the hemorrhoids. If it persists, come back, treat the hemorrhoids. And if it didn't get better, then we'd put a short scope in, and if we didn't see anything, then we'd eventually do colonoscopy. Now, with the rising incidence of colon cancer in young people, if you say rectal bleeding, you're getting a colonoscopy. So the threshold has come way down because the risks are going up, and we don't understand why. So now we are essentially overdoing colonoscopy to not miss colon cancer in a young person because it's so devastating when we do it, when we do miss.
So it's more so of a comment than a question, just kind of tying back to the colitis thing and irritable bowel syndrome. So I'm actually a pancreatic cancer survivor. I did not know anything about, luckily I didn't have to do any type of chemotherapy or radiation or anything like that, but it started out as irritable bowel, and then I started, it was like randomly, I ended up like getting sick and just consistently throwing up, and then they had to do a colonoscopy. So it's kind of like, I guess, maybe a question, I guess, would be, what is, how do you know, what is the question? I guess like with colitis, they were saying as they did the colonoscopy, it was like inflammation. So like, could that potentially turn into that, I guess? Or what are your comments on that and the symptoms between pancreatic cancer and then colonoscopy cancer, I guess?
Yeah, it's a good question. You know, the attribution of symptoms to a diagnosis is a daily challenge in medicine. We all struggle with it, and we balance appropriate testing with over-testing. And in some cases of over-testing, we have the chance of doing harm to people. So we have to be very careful about who we test and how. Having said that, there are many people who will carry a diagnosis of irritable bowel syndrome who might really have early signs of inflammatory bowel disease, and we don't find it until it's clearer that it's now inflammatory bowel disease. They can go years before that happens. Whether they're harmed by that is not clear. And as far as pancreatic cancer goes, it's the link between GI symptoms, digestive symptoms, and pancreatic cancer are much less specific. They're much less connected. So we'd have to have a reason to do imaging of the abdomen. And if a patient's symptoms persist long enough or don't respond to treatment, we would get around to doing that imaging. So I think follow-up is key. This is where doctors learn, from doing follow-up on their patients. So the patients have to say, hey, you know something, I'm still not better yet. Is there something else we should do? You know, some of it comes down to the patients being motivated, but the doctors need to listen and respond to that.
Thank you.
Any other questions? I would say if you know somebody who should be screened who's avoiding it, talk to them about getting screened and let them know they don't have to have colonoscopy right off the bat. They can do something non-invasive as long as they keep doing it. If they think they're going to be chicken to do the non-invasive stuff, have them bite the bullet, go with them and get their colonoscopy done with them. Yes.
Listening to you, and you're talking about the physicians, the health systems who, we could do a better job. I guess the one thing that kind of stood out is if, and I'm thinking about adherence, we do a lot of fit test type screening activities. And so are we doing communities a disservice if we don't go back to those same individuals the next year and then the year after that to remind them that, yes, you attended this colorectal cancer screening activity in your community, but that was just the original step. You still need to do a follow-up.
You know, I guess it depends on where the responsibility for screening lies. In a lot of countries, it's based on the government because the government pays for health care. In large healthcare systems in this country, like Kaiser Permanente on the West Coast, they are very good stewards of screening not because it's the right thing, not only because it's the right thing to do, it's going to keep their costs down, you know. And in other countries too, they're motivated to keep their costs down. We in the U.S. have fragmented healthcare, and so there's always the issue of, well, who's responsible for it? Is it the provider? Is it the insurance company? This is an ongoing problem with the fragmentation of our healthcare system. So, you know, does that mean we shouldn't have a fragmented healthcare system? Personally, I think, yes, we should not have a fragmented healthcare system, but the economics of healthcare they're out of their cage in good and bad ways. They need to be controlled better than they are. You know, we could do a better job. The U.S. should not have the current rates of cancer and poor health that it does, because the European countries that spend less on healthcare have better health.
All right, we will go ahead and wrap up the question and answer session right there for Dr. Imperiale. We want to thank you, of course, for your insightful presentation. Before we transition to the next thing, Cancer Support Community Indiana is in the back. Miss Nina, could you wave your hand? So they have provided colorectal fit kits, a limited amount. So for anyone here that's in person with us, please see them for a fit kit for more details. All right, so we're going to go ahead and transition into session 2 for today's conference, which is our guided panel discussion with our moderator, Lisa Hayes, who is actually the president of Pink Forever Ending Disparities. And we're going to go ahead and ask our panelists to come join us on stage as well. And as our panelists are getting settled, can we please go ahead and clap for our physicians again, as each of them did a wonderful job with the presentations they provided for us today. All right, and as they're getting settled, so next we'll have our guided panel discussion with different survivors and patients of cancer with us today. So they'll go ahead and delve into a little bit of their testimonies and what they believe advocacy should look like in today's day and age as far as cancer goes. So joining us today, we have Autumn R. Carter, Dorthella Osley, Wilma Hughes, Alicia Collins, Keith Brooks, and Sandra Bivens. So I will go ahead, now that they're all settled, and pass it off to our moderator, Ms. Hayes.
Well, good morning, everyone. It's still morning, right? Is this on? You hear okay? All right, I have been asked to facilitate this panel. It's my pleasure. We have some powerful folks up here. We do have some questions that I have been provided to direct to our panelists, but we're going to let this be a conversation, so I'm not going to necessarily ask each of you the exact same question other than the first question, which I'll get to, but also just be guided by some of your answers. And then at the end, hopefully we'll have a little time that if something in their conversation has sparked a question or comment by you all here, jot that down. If you're like me, if it was 5 minutes ago, I've forgotten it. So jot it down, and we'll try to pick up those questions at the end. That's okay. So we're going to start out. I'm going to ask each of our panelists to, again, introduce yourselves. I know Camille gave your name, but give us your name again. And within that, if you would be willing to share with us the type of cancer from which you are surviving, and also when you were first diagnosed. So I'm just going to go right here in order, starting with Wilma.
Good morning. My name is Wilma Hughes Sabatino. I'm a two-time breast cancer survivor, 2005 and 2017.
Thank you. Dr.
My name is Dorothella Owsley. I have non-Hodgkin's lymphoma, which is a skin cancer. I was diagnosed in December of 2008.
Good morning. Can you hear me?
Pull it up, sir. Yeah.
Good morning. I'm Alicia Collins. Glad to be here. I'm a two-time breast cancer survivor and diagnosed in 2014 and 2018, and currently I have a lung nodule that I am surviving.
Thank you.
Sandra Biven. I am a triple negative breast cancer survivor. This year in October would be my 10-year anniversary.
Good morning. My name is Keith Brooks. I am a prostate cancer survivor. I was diagnosed when I was 48 years old. Been surviving now for 5 years.
Hello, my name is Autumn Carter. Go by Autumn R. Carter, and I am a stage 4 breast cancer survivor, and I was diagnosed in 2019 at the age of 30.
Thank you so much for sharing that little bit. Now we're going to get into a little more details. And again, panelists, I don't want to ask you to answer anything you're not comfortable asking. So for this next question, I'll ask it, and then if anyone is willing to share that part, just indicate that, and I'll turn the mic over to you. Is that okay? All right. So could you share with the audience the first time you recall experiencing any symptoms caused by your cancer, by the cancer that led to your cancer diagnosis? Wilma?
Okay. The very first time I didn't experience anything, that was in 2005, because it was in my lymph or in my breast ducts. So that was a little different. And I had just had a mammogram, and they didn't find anything when they did, you know, the initial hand one. So that was a little different. Moving on, 2017, I was experiencing shoulder pain, back pain, and I just figured it was due to my job, because I have been in the manufacturing industry for over 20 years, so I just figured it was just the wear and tear of, you know, moving parts and, you know, that kind of thing. But in that, them doing in-house therapy, it just wasn't getting any better, so they sent me for an MRI thinking it was a work-related injury, and that's how they found that I had had a growth, and it had moved, since I had a mastectomy, had moved to my lymph nodes, which it all went from there.
Thank you. Anyone else? Autumn?
So my breast cancer started with a menstrual cycle that lasted for 2 weeks. And then I also had a nipple that was sort of touched, that also followed by an inverted nipple down at the bottom. And I state that because I think that's really important, a really important piece, that people just look for the lump, but you also have to look for any nipple changes. So I had a nipple change, and then I want to say maybe about 3 months later, I had the actual lump, and I found that through self-examination.
Thank you, Autumn.
You're welcome.
Keith?
Yeah, so when I first had experiences, you know, I had a lot of fatigue. I had a tremendous amount of weight loss, like drastically, all of a sudden. Didn't really know what was going on, and you know, my first thought was to go get checked out, to go and see my doctor. I didn't know what to ask. All I knew was something wasn't right, and so they asked if I wanted to do a PSA test, which is the first non-invasive test that a man can take for a prostate examination. And so I did that, and the test came back showing signs. So I went back for the digital exam that led to a biopsy, that led to me showing that I had prostate cancer.
Okay, I think it's interesting to know, out of the 3 panelists so far, what has been key is they listen to their body. They notice their own body change. And some of it was not necessarily a known factor for the disease that they were eventually diagnosed with, but they listened to their body. Right. All right. Did anyone else want to respond to that before we move on? Sandra?
For me, my journey actually began when I was a freshman in college. That was when I first noticed a change in my breast, and I noticed a nodule. So if you can imagine a young girl of 18 being thousands of miles away at school, because I was in New Orleans, calling my mother, half crying, halfway smiling, trying to keep it together to say, "Hey, Mom, I found a lump." And I could hear the break in my mother's voice and her saying, "Okay, I'm going to call you back tomorrow." From there, you know, she did call me back. She called my physician. A week later, I went in to, you know, remember, I'm new to New Orleans. I don't have a doctor. I wasn't going home to have anything done. I was in school, at school. So, you know, my roommates, they're the ones who gathered me up and went to the doctor with me, a doctor who, you know, for me, he was very insensitive. From there, I've had a mammogram, you know, from the age of 18 on. During the end of 2013, I became ill with a small bowel obstruction, and I had surgery in 2013, which meant for me, I missed my annual mammogram, which is always in January on my birthday, because that's what I decided to do. That was my present to myself. So I missed it that year. I went into the doctor for my follow-up for my small bowel obstruction, and my doctor says to me, "Hey, you missed your annual exam, and we have to get you back on schedule because we don't want anything to happen." And I said, "Oh, okay, sure, great." Scheduled it. A few weeks later, went in. A day later, they called me back in and said, "We need to do another mammogram. It doesn't look right from the time that you were here last year. There's a definite difference." And from there forward began my journey.
Thank you. That's a nice segue into one of the other topics we're going to explore when you said you felt like that the initial doctor that you saw was insensitive. I want to kind of throw that out to the other panelists. What has your medical care experience been regarding your cancer diagnosis and treatment? Dorthella.
Since I have skin cancer, and it's generally the perception that black people don't get skin cancer, but we do. When I was first noticing a change in my skin color, it was just on my face. There was a area on my bicep and my thigh that was light. So the very first dermatologist I went to said, "Oh, go get some sun." That was at VA in Pennsylvania. But when I was reassigned to Illinois, I went to the dermatologist there, and they did kind of a biopsy, but I didn't find out the result of it because the doctor was deployed. However, they started me on light treatment, UV light treatment, and I did that 2007. So then I was retired from the military in 2008, and I went to the VA here in Indianapolis. And so just so happens there was a doctor from IU, and she says, "I think I might know what's wrong with you." And so she did 2 biopsy punches. And so when I was due to come back to get the stitches from my punch, the nurse, I said, I'm here to get the stitches removed. And the nurse said, "No, you need to see the doctor." I said, "But no, I'm here to get the stitches removed." And he said, "You're going to see a doctor." So they had to squeeze me in to be able to see a doctor. And it was a resident that finally came in, and the resident says, you know, "Well, yeah, we found something." And she gave me the generic name, which is mycosis fungoides. And I said, okay. She told me that I'd have to come back and get some blood work done. So that was all she told me. So I went home and went to the computer and looked up what is this? And I found out it's a cancer. So I was really upset, you know, that I was brushed off like that. And so from there, they brought me back. They said, okay, come in, we'll talk about it. And that's when a doctor from IU came and told me that it was a skin cancer. And they started me on nitrogen mustard, which is a topical chemotherapy.
Thank you. Autumn?
So my first experience with breast cancer, in a timeline, in a nutshell, when I first found out that my nipple was inverted, I went to the doctor and they brushed it off as a fibroid, basically telling them that I know my body, and I had asked for a mammogram, and they told me that I could not have a mammogram because I was not 35 yet. And they had asked me if breast cancer ran in my family, and at that time I did not know that it did, and it still does not. And so I told them no, and so they basically told me that they would not be able to further help in that area, and that it was a fibroid, and they would basically have me referred out. Another experience that I had that was not the greatest is waking up from surgery and interacting with a nurse. She had asked me to get up and walk, and I had a double mastectomy. I'm okay with sharing that. And she had asked me to walk, and I told her I could not walk, not understanding that the breast cancer had spread to my spine at that point, but I had no idea at this time. She didn't either. And her response to me was, "You still need to walk. There's 60-year-olds that can do that." And so that didn't sit well with me, and I felt very little in that moment. And there's also another experience that I had with a doctor where they missed my PET scan. They had my PET scan first before after they did my surgery. And it's really up to the doctor to do the surgery before or after the PET scan. But in this particular case, they chose to do the PET scan after the surgery. And so the reason why I bring that up is because mine was not just waking up and finding out that it was stage 4 breast cancer. It was progressive. It went from stage 1, stage 3 to stage 4. And so if they would have caught that at stage 3, they would have been able to do the PET scan initially and then have me undergo surgery. But I'm grateful that the treatment happened the way it did. I didn't have to go through chemotherapy, and my heart is with those who do. But just sharing my experience with breast cancer and healthcare disparities.
Thank you. Anyone, any other panelists? I don't want to skip over anyone sharing that experience. Wilma?
Initially in '05, when it first was known about my breast cancer, and being in the ducts, you know, I went through, I had denial first, and then, you know, my husband pitted me against with the kids, and, you know, he didn't want to do life and that type of thing. So with that being said, I had the surgery and had a mastectomy on the left side, and after all, you know, the doctor ended up saying, oh, well, after, you know, taking, you know, some samples, well, we see a trace. A trace is small, like a grain of sand or something to that effect, but you have a 1 in a million chance that that would come back. Well, 12 years later, 2017, it's back, but not only that, it spread to my lymph nodes. So I was not impressed with that, because in my mind, if you see something, then you act on it. I don't care if it's 1 in a million or what have you. A grain is a grain is a grain. So I was not impressed with that. So, and at that time, I wasn't as active or taking too much, lack of words, interest in it. I just wanted to be done. Now forward, I'm active. I'm more outspoken for myself. If nobody else, for myself. So that was my experience.
Thank you. So one of the things that you just said that kind of sparked my attention is the fact that you're now more active in your treatment decision making, it sounds like. So that's a nice segue into one of the other areas we want to explore is what's one thing you wish you had known early in your cancer experience that you now know? Autumn has her hand up.
I always stress this to anyone who is seeing a doctor for any type of symptoms that they may be experiencing, is to have the doctor document your chart. You know your body better than they do, and they're only going off what they've learned in school. They're not in your body. And so if I would have known back then to tell the initial doctor that I had encountered who brushed it off as a fibroid, I would have asked her to document my chart. That way they can go back and see, hey, she asked for a mammogram and it was not granted to her. The other thing that I would say if I knew better, I would definitely say to ask for the actual procedural, the overall what that looks like. Because if I would have known to ask to have the PET scan first or to have it afterwards, I would have known to be a better partner with my doctor in my care, to have a say-so in, hey, I don't think we should do that here. Maybe since this is like something that's not, it's really recommended to do this here or there, I could have had more of a say-so in that.
It seems like you all have learned so much during your cancer experience. So, Keith or Alicia, you've been a little quiet. I don't want, I know you have something within you to share with this audience.
So during my experience and when I came out, my biggest thought was, having a little more faith that everything was going to be okay. When I got diagnosed, I thought the world was over. I cried like a baby. I didn't know what to do. It took about maybe 2 weeks or so before I had to actually wrap my mind around and say, all right, I got a problem. Now what am I going to do about it? So I really started looking into what to do about it, doctors I should see, what are the surgeries or whatever that may come about, or the modes of medicine that I could go through to cure my cancer. So again, my biggest thing was having faith in my doctor. Again, I was really scared. I experienced a radical prostatectomy. That was, again, something to wrap your mind around. But at the same time, my doctor assured me that he would give me the very best treatment that he could. Because I told him I wasn't coming to the surgery. I don't know if I'm coming, doc, but he said, I need to see you here. And it was the best choice I could have made. Again, it's been 5 years. I'm here, I'm alive, I'm doing very well to experience some of the things that I have. And I just want to let everybody know that just because you get diagnosed with a disease doesn't mean that the world is over. So again, have faith in our Creator who put us here, and know that He can help us through any situation.
Yes. Alicia?
So my journey started in 2014, and it was stage 1, actually stage 0. And so my doctor was like, don't say that out loud, around other cancer patients, because technically it's not really cancer, but I had a lumpectomy the first time. And in terms of when I was diagnosed, I had started my screening, my mammograms at 35. And I felt that, and it was from my gynecologist, and I feel like I had a very progressive gynecologist. All of my doctors seemed to be forward-thinking and very progressive in their thinking and around treatment. And so when I was diagnosed in 2014, it was a total shock because I had no symptoms. And just like him, I thought my world was, just got married that same year and felt my world was going to end. For me, what I know now and then is I will focus on what I could control. Because with cancer, your life changes, and it could always be around appointments and doctors and treatment. When I first diagnosed, I was in Google all the time. I was bringing research and ideas and things to my doctors, and they were like, no, 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 that's not what you have. So I had to learn to remove myself from the availability of source materials. I was with, I'm with a different healthcare system now, and this speaks to the fact that I had to become my own advocate. I had to become my spokesperson. I had to become the one who pressed. I would always bring someone with me. My mom's in the audience today. She has not missed an appointment with me, any of my surgeries or nothing, because sometimes I may not hear everything, or there may be a question that I'm not even thinking of. And another thing, I document everything. So my phone, my notes is filled with the summaries. You don't have to send me the notes from the appointments, because I have them myself. And then I always keep a record of how I'm feeling, a diary of everything of how I'm feeling. And then I had a lump in 2019, and so it was stage 2, different breasts. So I opted for a bilateral mastectomy. And so that is where I've had the most challenges, is with side effects from surgery, and with moving through the effects of chemo and those things. But again, I focus on what I can control. I work on my mental capacity and my faith. The cognitive and the thoughts, that is what can paralyze me. And so I always have to be positive and forward thinking, and then also get outside and do things that I enjoy. So I'm all about living and having the best, because I want to make sure that I am demonstrating my faith, and just grateful for being here.
We have just heard some powerful tips and messages from all of them. I just got to stop right now. We're not finished, but sharing these takeaways for folks is just very powerful, and I appreciate it, and I know they do too. Another question I want to pose to the panelists.
If I may, Lisa.
Oh, I'm sorry. Go ahead, Sandra.
That's okay. My thing was knowing about my family history. I heard, as growing up as a child, Aunt so-and-so is sick. But as a child, you do what? You stay in a child's spot. So there was no questioning, well, what's wrong with Aunt so-and-so? Growing up, I heard cousin so-and-so isn't feeling well. Uncle so-and-so isn't feeling well. But again, as a child, you go outside and you go play with the rest of the cousins and you have a great time. So for me, it was, I wish I would have known what was wrong with Aunt so-and-so and cousin so-and-so and Uncle so-and-so. Because for me, after all of the people in my family that have been diagnosed, and it is extensive, none of them ever received genetic testing. I was the first. And it blew my mind, because I'm talking with my aunts and my cousins who have been through the breast cancer journey, and I'm asking them, were you genetically tested? Because if you were, then that means I don't have to be. And you could just tell me what the doctor told you, and then I could tell my doctor, and so on and so forth. But everyone came back and said, oh, no. Oh, no, I didn't want to know, because that was my next question. Well, why not? I didn't want to know. I just knew I had breast cancer, and I wanted it to be done and over with. I had ovarian cancer. I wanted it to be done and over with. I had urine cancer. I wanted it to be done. And I'm like, are you serious? Out of all of you, you're all telling me no? So for me, I wish I would have known, because I think in my little mind that even at 18, I would have been like, well, can I be tested? And perhaps maybe just a fleeting thought, in 2013, perhaps I would not have been where I was. Don't know, but at least I would have had some type of ammunition going forward.
Absolutely. Anybody else before we move on? All right. So what did you find to be your biggest comfort, sort of your go-to when you were having any complications with your treatment or survivorship?
Prayer.
Yes. Going to God.
Yeah. Dr. Bell?
Mine is because I look at my sisters being diagnosed with breast cancer, both my sisters. My daughter was diagnosed last year, father and 2 aunts. But I look at mine, even though mine's not curable, I will probably be having treatment, some type of treatment the rest of my life. Someone's worse off than me. So I look at it that way. Sometimes I get kind of down because I have to take treatments every day, and it's been going on since 2007. So sometimes it kind of bothers me, but there's always a brighter day ahead. I have my faculties, I have the use of my limbs, and I know the Lord is watching over me. Yes, mine can spread to my lymph glands. It can spread to my organs. Because I asked the doctor recently, I said, well, what happens if I quit taking the treatment? She said, it's going to spread, and it has spread over the years. I don't know, something about COVID, it has spread to more areas, but I'm glad to be here, and I'm just gonna do my thing and live my best life.
That's right. Keith?
I remember when I was really going through it in some of the bad days, I was wondering if there were any support groups that I could have spoken with, you know what I mean? Men like myself that was going through it. And as I reached out, as I did all of the research, I found nothing. It was one of the most depressing things that I ever could have experienced. So when I came out and was feeling up to it, I spoke with some people from the Cancer Network and offered my services to be able to bring black men together, to be able to talk about this subject. Because, man, every time I talk to a man about prostate cancer, it's surprising that a lot of them, over 30% or 45%, will tell me I'm a survivor as well. But if the subject doesn't come up, you'll never know. So how do we help the men that may be going down that road, or that may have those cells within their bodies that haven't quite developed yet? How do they get to know what's going on and how to handle the situation and what to do without creating these community networks or these networking groups?
Right.
I think that's something that needs to happen.
Thank you. Autumn?
I know that someone had mentioned prayer, but I truly do think that for me, it's always been going to God, because I feel like, to me, you have your family, and that's a huge part of support, but there's nothing like being alone with God to really process your feelings and your emotions. Because when you're going through things, you really just need that time by yourself to just not see other people crying. Because I know with myself, one instance was my mom had called, and she did this lovingly and willingly, had called family when I was diagnosed with stage 4, and they all came. And that was just overwhelming for me, understanding that there was that support, but also understanding like I had to watch people cry, and that made me want to cry. And I'm just like, I don't need to cry right now. So just like spending time with God, and then also too, therapy was a huge thing for me. And I'm so sorry that you weren't able to get that therapy that you needed. For me, I chose not to do group therapy. I just was not ready for that. So I chose one-on-one therapy, and that did a great deal for me to just be myself and be vulnerable and to really talk about my feelings with someone who doesn't understand what I'm going through, but they're just there to listen. And then also understanding that they've been with other breast cancer patients. So they're sitting in the seat of working with patients who are in similar situations. So you're not saying anything that's not relative to what they haven't heard, if that makes sense. But I think to me it makes a huge difference when you're talking to someone who is equipped with the skills to kind of help you navigate your emotions, your feelings, because it's a lot. It's a lot. At 30 years old, I just never thought I would be diagnosed with breast cancer, and it was a huge chunk to bite off. So therapy definitely helped with that.
Thank you.
You're welcome.
Anybody else, your biggest comfort, your go-to for well, in the good times and the challenging times of breast cancer. All right, so I am going to move on. Somewhat of a related question to wrap up with, but then afterwards we'll see if there's anyone in the audience that wanted to hear more about a certain topic. But if you could only share one thing with this audience today that you want them to take away about survivorship, living with your form of cancer in your survivorship, what would that be? Now this time I am going to go right down the road here and say as much or as little as you want. So I'll start with Wilma.
I just think it's just knowing yourself and being true to yourself and advocating for yourself.
Thank you. Dorthella?
I agree, because I should have asked questions, but when we go, we don't know the questions to ask often, and the doctors, nurses may tell you the minimum, but just having a positive attitude and living your best life.
Same theme. I just say, I use the word a lot, but just be empowered. And if that means you have to bring someone with you to ask those questions, I'm one that I will have pre-questions. So, you know, but that's when you already know. But when you're in that space of, you know, you're not getting, you have your test and you're waiting, I guess that waiting time too, you know, for me is having a prayer circle, is also being able to, I'm with Autumn, just the quiet time, and, you know, having that support is key, that you need, the type of support that you need.
Thank you. Sandra?
For me, communication. Communicate what is really going on within your family, because that can save you some heartache perhaps. Communicate what is really going on with Aunt so-and-so and Uncle whoever, because again, if you don't know, you know, that's where the issue lies, is we always, you know, the doctor asks you a question and you're looking dumbfounded and you're saying, oh, I don't know. My thing is, why do you not know? You have family, have the conversation. Someone needs to become the medical historian, I say, of your family. At least one person needs to step up. For me, I became that person. So I just encourage you to look to your family, look to yourself, and figure out who can become that person and who can assist you in advocating for yourself. Give yourself permission to become your best advocate.
Thank you. Keith?
Well, as the ladies have all stated, that becomes a process of learning yourself. You get a real true identity of who you really are once you go through some of that pressure. You know, pressure creates either a burst pipe or a diamond. So I like to look at us as diamonds sitting here today on the dais, and that we've all come through a large problem. And then again, if you do the research about your disease or your disease state, gives you a lot of power. So, you know, the knowledge is power. The more you know about what you're dealing with, the better you can deal with it. And again, that family support, or it may not even be family, whatever support that you can find. I advise you guys to use it, and use it to the best of your ability.
Thank you. Autumn?
My takeaway would be to partner with your doctor, to really understand that you have a say-so in your care. It's not just them forcing something down your throat. It's not just them telling you what you should be doing, but it's you advocating for yourself and saying, I don't know about this. There's been plenty of times where I was scared to do whatever it is my doctor asked me to do, and I told him, I don't think I can do that. He's like, okay, let's find another avenue, a different route. And so the goal is for you to get better, and so you have to be vulnerable with where you're at to let them know that, hey, I want to partner with you on this. Also, too, reach out to the Pink Forevers and reach out to the cancer community centers. They're there for that reason. They've done all the map work and all the legwork for you. You're literally just trying to process this diagnosis, but they're there to really walk you through this thing, and you don't have to be by yourself. And then also, too, lastly, I would say my last takeaway would be that When you're diagnosed with even stage 4 breast cancer, it's not the end. And like they have all stated, it's really the beginning of a beautiful journey to really unravel from whatever, and to really just open yourself up to these new ideas of who you're about to become through this journey. So,
thank you. Let's give these diamonds a hand. All right, before we wrap up, I do want to allow the audience, if you have any comments or questions. Camille has the mic, if you could indicate if you wanted to make a comment.
So I am Autumn Carter's mom. She always says, "Mommy." But I just want to say thank you all because I watched my daughter, of course, she's 30, and see her ups and downs and being with her and walking with her. But listen to your journeys. It's just so amazing what you guys have shared from what I've seen with my daughter. Does that make sense? And then just hearing how you guys advocate for yourself, you ask questions, because the things that you guys shared, me as a caregiver, it resonated to me because when Autumn and I started on the journey and I had to go into the office and we had a navigator, but they gave us all this stuff to go home and read, and I'm like, what is this stuff? And so I'm like reading it, but I don't understand what it is, right? So the things that you guys shared is so important as breast care, as cancer patients, but then also for the caregivers, because as you were saying, I'm sorry, what's your name again?
Sandra.
Yeah, Sandra. You were saying that someone in their family needs to be the advocate, right? So I learned to be the advocate. I learned to read, ask questions, try to push Autumn along. And so I get it. So I just want to thank you all for being diamonds and taking your time out today to even share your stories, because it's impacted me to see just and African Americans as well, so it's so touching and heartfelt to me to say that you are strong people and you're willing to step out your box to be vulnerable and share in this space. So I'm so happy that I was able to support Autumn. And then also I want to thank Pink Forever, because they came into our lives almost 3 years ago, I would say, and not knowing when they came into our lives the things that they have brought. I can just go into tears.
Thank you.
Because the beauty they have brought to my daughter and me, at one point where I was like, okay, I'm stuck here, I don't know what to do. And God said, you called on me. You're my child. I have something for you. And they showed up. So I want to thank you so much. And I also want to thank Nadia. And so what Autumn said, when you can get with those cancer communities and those Pink Forevers, step out. And if you have an advocate, share the wealth with them as well, right? Your caregiver. So I apologize for the tears, but I just want to say thank you guys. And I'm so grateful to be here today to share in this. And that's all I have to say.
Thank you. Thank you.
No, I'm emotional. I want to thank you for what you said, and don't apologize for the tears at all. I know I mentioned briefly in the opening my own health journey. So you standing up, and I'm all for the moms. My mom is actually here in the front row supporting me today. So I definitely understand, and I'm sure my mom does too, what that advocacy looks like in times of uncertainty. So I want to thank you personally for mentioning that.
Thank you, Camille. Firstly, thank you all for your stories, because like Autumn's mom did mention that it impacts everyone. So thank you for sharing. This question is for the gentleman. I'm sorry I forgot your name, but you did mention that you're going through your process and talking to other men about cancer. My question for you is, how was those conversations? I know men typically shy away from admitting that they're going through So how was those conversations?
Man, you're right. A lot of people are going to admit it. They're not going to mention it. But what I found is when I opened up, really they opened up because it was a common ground. And because not many people talk about it, this is just, you know, I make it a mission to talk about health and wellness in my life. So when I'm sharing with somebody, that's me just opening up. And it's up to them to reciprocate. So most times, like I said, when I'm talking with someone and they share that they're a cancer survivor, then we really open up and become like bonded immediately. So not really afraid to talk about it. I'm afraid to be on the stage right now.
It doesn't look like it.
Yeah, I took it to church and talked about it. Should we do this? But the more that we do talk about it, the more that we can help the next person or the next human. And again, that's how that we all stay together, helping each other.
Did we have any more questions or comments from anyone that's joining us live today?
Oh, can I say one thing? Men, if you're 45, please get checked. Please. It's as simple as doing a blood test. The first blood draw, that's pretty painless. It's the first way to get checked out, all right? Painless. Please do that for yourselves.
Hi, I just want to say that my daughter also is on the panel, and she cringes when she sees me stand up. But number one, I just want to say you guys are awesome. I have enjoyed everything, and everything that you have said is true. And when Sandra, when you talked about family not knowing, that is the most important key. I'm 78 years old, and my family never talked about illnesses, let alone cancer. I tell my children everything. 25, 30 years ago when I had thyroid problems, I told my kids. Even when they didn't know what I was talking about, I told them. We have to be an advocate not only for our family, but for the community. And I think you guys have done an awesome job. Number one, what you all said about keeping God in your life or having the faith, that is so important. And a lot of us are private people. We don't like to talk about our condition. Most of us really and truly are. But thank you so much for stepping out of your comfort zone and telling everybody what the journey is like. I know from my daughter what the journey is like. And speaking from mother to mother, I am an advocate for my daughter and for other people that I know who have. So we have to support each other.
Did we have anyone else that wanted to ask a question or make a comment to the panel today? Well, I want to go ahead and thank everyone that volunteered to serve on this panel today. I know that sharing your story is not easy, especially when it's a vulnerable story and a testimony. So I want to thank you all for being courageous enough to do that with us today. I want to thank our moderator, Ms. Lisa Hayes, as well, for leading such an invigorating discussion. And I want to invite you all to network more with these panelists, ask them more about their stories, as this is a once-in-a-lifetime opportunity. Vulnerability is not something easy to do. So while they're in this state, please go ahead and take advantage of that, and please talk to them. I also want to do another non-shameless plug. Autumn is actually here today, tabling back there with her book that she wrote. So I encourage you all to visit her table, speak with her, and learn more about her book as well. All right, so we're going to transition into what everyone's been waiting for. I'm sure you heard it and smelled it. We're going to go ahead and transition into lunch. But first, just a few announcements. First, again, I would like to just thank our panelists and give them one more round of applause because there's not enough round of applause that we can give you. So thank you again. Lunch for those that are joining us in person is located on my left side of the gatheratorium space. It is self-serve, and there is hand sanitizer, and it's also two-sided. So once we conclude, please feel free to grab lunch, grab seconds, grab thirds, because that is a lot of food, and again, I do not want to pack that and take that with me. I also invite you to browse the tables of the organizations that are here during the lunch hour. They have all taken time out of their day on a Friday. It's cold, but it's a beautiful Friday. And they've taken their time out to be here with us and share their resources with us. And a lot of them have vital information and surveys to advance this research for everyone here today. So I encourage you to connect with them all as well. Next, I want to, again, shamelessly plug the surveys that we have today as well. For those of you that have not filled out a registration form, whether online or in person, please, if in person, please visit the National Center for Racial Equity and Inclusion table. Please fill out that registration for us. We're using it to further advance our work and our research within health equity to see how we can better serve the community demographically. For those online, you have a lovely QR code that you can scan as well. We also have another survey provided by the IU Health Simon Cancer Center, a community interest form, same purpose, just wanting to survey how we can better service the community. So please, either if you're online or in person, go ahead and scan that IU Health interest form that we have, or if you're having trouble scanning, please see me, and I can help you fill it out as well at that National Center for Racial Equity and Inclusion table. Lastly, for those of you that are joining us in person, on the back of your schedule, you'll find a QR code. That is for the event evaluation survey. We want to continue having these events, but we also want to make sure we're tailoring them to best service you all. Again, if you are online, you can scan that up there. That says evaluation. And we just want to make sure that the events that we're hosting are tailored to you all and the population we're servicing in the greater Indianapolis community. Lastly, before everyone is dismissed to eat, we're holding a couple of raffles today. So our first one is provided by the National Center for Racial Equity and Inclusion. 10 people here with us today, whether panelists or presenters, you are not excluded. If you visit the Martin University admissions table, it's located up here by the double doors you enter to with Irvin over there, that's waving. If you visit that table, learn more information about Martin, you will write your name down and be entered into a raffle to win some NCREI merchandise. I'm not going to say what it is, but just know there is some goodies in there for you all. And also we have another raffle that is provided as well. I'm looking for Allison. There we go. Everyone see Allison waving. She's providing a research provided by the Komen Tissue Bank. So go back there and visit for more details on that and how you can win. For those joining us live, we're going to go ahead and take a break for lunch. We will return at 1 p.m. with our keynote address by Ms. Nadia E. Miller. I encourage you all to eat as well. For those of us in person, we're going to go ahead and break for lunch, and I thank you all for joining us. In your spare time, we are also live on LinkedIn and Facebook, so those of you in person, if you would like to share that live stream link with those in your network who can join us for the keynote and the rest of the conference, that would be amazing. Thank you. We hope you enjoyed your lunch. For those of you joining us virtually, we hope that you took this time to eat as well. We're going to go ahead and continue with the agenda and transition into our keynote address. Powerful, engaging, and knowledgeable. These are just a few of the words that people use to describe Nadia E. Miller. She leverages her formal education, her real-world experience, and her passion to motivate, inspire, elevate, and empower others. As a workshop presenter, lecturer, and keynote speaker, Nadia offers pragmatic steps for people to change and enhance their own lives and the lives of others. Nadia earned a Bachelor's of Business Administration from Indiana Wesleyan University and then worked in the corporate sector and as a small business owner and business consultant. Nadia was diagnosed with breast cancer as a young 28-year-old. That life-altering experience drives her passion for breast health advocacy. In 2008, Miller, with the facilitation and coordination of her brother John M. Miller, founded Pink Forever Incorporated. In order to ensure that the minority community, especially women, would receive comprehensive information, support, and resources regarding breast cancer, health, and prevention. Nadia now serves as the president of the board of directors of Pink Forever Ending Disparities. Nadia E. Miller has used her gifts and expertise to serve other organizations and groups whose missions are aligned with hers. She has served as the chairperson of the Circle of Promise Committee. She was the first African-American honorary race survivor for the Susan G. Komen Indianapolis affiliate. In 2016, she was awarded the Black History Maker of Today by McDonald's. The award recognized the totality of her work as an influential role model in the central Indiana community. In 2021, the American Cancer Society chose Nadia to deliver the keynote address at its Discovery and continues to be highly sought after to speak for organizations at the national level. Nadia was instrumental in creating the Stay Alert, Stay Alive Breast Health Summit, an annual event that brings together healthcare professionals, researchers, community members, and survivors, caregivers, and policymakers for a day of learning. Please join me in welcoming our keynote speaker for today's conference, Nadia E. Miller.
Good afternoon, everyone. Good afternoon, everyone. We've had an amazing morning, haven't we, today? I'd like to thank Martin. We'll give you all a round of applause. IU, Cancer Support Community, and of course, Pink Forever for your labor of love here today. I just really appreciate it. I am honored just to be here today. I want to say that. Anytime I have the opportunity to go before people and share and talk and teach, it is an humbling experience, specifically with our community, and so thank you. So I'm just going to get right on to it. Interesting thing enough today, the theme has been about advocacy, and so today my talk is going to be about advocacy. It's not just a buzzword. That's going to be our talk. About 16 years ago, I met a young woman, a young Black woman who was 28 years old. She was poised. She had a 2-year-old daughter, and she was living life. I mean, she worked for a Fortune 500 company, and one day she received a diagnosis of breast cancer. I'll tell you a little bit about her pathology so you can kind of understand what it was like for her. At 28 years old, she was diagnosed with breast cancer. She also had the gene mutation BRCA1, which increased her risk for breast cancer and ovarian cancer. She also was triple negative. It's a triple negative breast cancer, very aggressive breast cancer. She's 28 years old. Because of this her pathology report, her treatment looked a little bit like this: a year of chemotherapy, a double mastectomy, and a total hysterectomy. She could no longer have any children at the age of 28. Oh man, this young woman, she taught me some things. As I learned to get to know her and grow with her, she taught me how to persevere. She taught me how to smile in the face of adversity. And she taught me most of all how to be an advocate. And I appreciate her right now to this day. Arguably, it's one of the reasons why I stand here. And if you don't mind, I'm going to take a second. She's here with us today. I'd like to introduce you to her and who she's become today. Is that okay? Give me just a second. I'm Nadia Miller. I'm a 16-year breast cancer survivor. It's nice to see all of you and meet you. The reason why I tell that story is to learn and grow with her, because the scared, young 28-year-old young lady is now a 44-year-old, 16-year breast cancer survivor who is an advocate. Yeah? I hope as I continue on, because I'm a teacher by trade now because of what she taught me. This young girl who was scared, feared, and anxious. Because honestly, fear and anxiety, they ride in the same car, just so you know. And at times, you know, fear starts talking to anxiety, anxiety starts talking to fear, and then next thing you know, they pressed on the gas and they're running down the street making all the decisions. When the reality of the situation is knowledge, you already know what I'm going to say, is not only power but fuel to do what we need to do here in our community and abroad. And so in this conversation, we're going to put fear and anxiety, we're going to put them in the back seat, right? And we're going to work with what it means to truly be an advocate. Because it's not just a buzzword. To be an advocate is weighty, right? There's something behind advocacy and what it means to be an advocate. Today on the panel, I absolutely enjoyed, because I didn't know what the panel was going to be about, just to be honest with you all. I didn't know. I didn't get any notes. I didn't get briefed. But once again, the atmosphere responding to what today was supposed to be about. I didn't talk with Camille or anybody about what this keynote address was going to be about. And so to tie it all together, I want to teach and I want to talk about what advocacy truly is. Truly is. Because it's not just a buzzword. So often we hear, and it's fortunate and unfortunate at times, we get these words in our head like patient navigator. But we really don't know the strength and the weight behind what it means to help an individual, a patient, navigate through the continuum of care. But we say it. We don't really understand what advocacy in action really, truly means. It's more than just a voice. I would argue and offer to you that there are really 3 types of advocacy, but first we need to find out, what is an advocate? What does it really mean? It's simple as this: getting support from another person to help you express your views, your wishes, and help you stand up for your rights. Someone who helps you in this way is called an advocate. You got a little sign language too when you do. It's called an advocate. Roles as advocates are very important too, because they take on different shapes and they take on different forms depending upon who you are, what your need is. Because sometimes you have to be an advocate for the voiceless. Because that scared young lady I told you about who was 28 years old, there was one point during her journey where she could not speak. She was overwhelmed and consumed with words like mastectomy and hysterectomy and BRCA positive and radiation and all of these things that took her voice away. She needed an advocate. She needed a support system. She needed something weighty. A role as an advocate is super important as well. It is to offer independent support, to be completely honest with you. And sometimes, between self-advocacy, which is when an individual advocates for themselves. You heard these lovely survivors up here on the panel talk about, I think Autumn Carter said something like, I partnered with my physician and my doctor about my health care. I heard another survivor talk about the fact that I had to be my own advocate. I had to be my own voice for me. I think I also heard another survivor talk about the fact that if I didn't do it, who was going to do it? Advocacy. Weighty. Heavy. It's got to mean something. And then you have individual advocacy, is the ability to effectively communicate really and convey messages on behalf of an individual. I lost my voice. So at one particular doctor's appointment, when they were saying all those big words, mastectomy, didn't tell me what it meant. Some of you have heard my father was in the waiting room with me, with the rest of my family, which, by the way, are the most animated group of people you will ever meet in your life. Dr. James Crossan comes in, simply says, we're going to remove your breast. And my father jumps up and says, that's exactly what we're going to do. We're going to remove our breast. Funny story is, though, I needed an advocate. I needed some help. Now, that wasn't the voice I was looking for the one to chime in for that particular thing, but you all get the theme that I needed someone, I needed some help. And so there they were. And so what we have to do, and we have to remember when people are talking about in the community about advocacy and how they're advocating, we also have to remember that sometimes when you're advocating for other people, you have to know what you're advocating for. Because my needs are not her needs are not his needs. And so make sure you're having that conversation if you're going to be, or since you are, most of you are here, would consider yourself an advocate or a caregiver for someone else. And systems advocacy. Now this is super important because this also involves laws and policies and being at the table and having a voice there. Because that's actually legislatively where we've got to start when we talk about screening and guidelines and this dis-ease that's impacting black and brown and beige people. Screening guidelines that need to be sooner. If it is true that a young woman can be diagnosed at 19 and 28 and she has no known family history, should we really be getting screenings at 40 and 50? I'm just posing some questions. We're going to think together. So often when we are together in this community, the community we live in, we work in, and we worship in, we forget that we must have actionable items that we can actually carry out that's heavy, that's weighty. Because to me, advocacy really looks like legacy. It looks like that 2-year-old little girl that I was talking about when I met that 28-year-old woman. It looks like legacy, where she can be 18 years old today and off enjoying her freshman year at college for advocacy, which translates to legacy, if it's advocacy in action. It's weighty. It's heavy. See, advocacy should involve people in the service of them. It should involve really taking up someone else's concern for them to live through, to journey through. You often hear survivors talking about my journey. I wouldn't take anything from mine. I wouldn't take anything from mine. But what I would do is give the gift of advocacy to someone else. And so today, as I really sit and I think about what happened in the room today, and I look at all of the vendors and this life-saving information that is here, community advocacy looks like unity. It looks like leaving here today, making sure you stop by these vendors, every single one of them in here, and taking something with you to pass along to someone else that, number one, couldn't be here today, 2, didn't think it was important, or 3, is watching it virtually. Pass along the information from the people that are here today. It's not only free, it saves lives. If it's something isn't true, there shouldn't be any evidence. You've seen it today. You've seen it today. You've seen story, and you've heard story, and you've read story after story of colorectal cancer survivors, prostate cancer survivors, lung cancer survivors, breast cancer survivors. Data, numbers don't lie. Black and brown and beige people are disproportionately affected by these diseases. So what are we going to do about it? What are you saying, Nadia? What I'm saying is, what's a power play, right? Do you realize what a power play is? I called Lisa one day. Those of you that don't know who Lisa is, Lisa Hayes is the best executive director here in Indianapolis from Pink Forever Ending Disparities. She's also my partner, little side plug. It's not shameless. That's my partner. But the power play is intended to increase a person's power or influence. That's a power play. And so I'm charging you all with today to think about what is your power play. Is it knowledge? Increasing your positioning and your presence and your influence? Is it advocacy? Is it coming along someone individually? Is it being an advocate for yourself? Is it being an advocate for systems? Is it community advocacy? What's your power play? Is your power play being bold enough to say, hey, this thing is happening to my community and I am outraged by it, and it should be an outcry, and it is, that black and brown and beige people continue to die at a disproportionate rate than our Caucasian counterparts? It's okay. What's your power play? What's your move for this thing that is impacting so many people's lives that didn't even sign up for this thing, but now we are compelled to fight together? We are compelled here in Indianapolis and abroad to come together to fight this thing that has disrupted. It's not just the survivor's life, but you've heard it here today too. It has disrupted the entire family, whether that be a relative, extended, or someone that you call sister or brother. So as you see, there's this button to remind you, this is your charge. Your charge is to put on this button. And your charge is to remember when you see this, whether it be on your kitchen table, whether it be on your fridge, or it be on your table. Remember your power play. Whether it be around cancer, whether it be around your children, whether it be around advocacy, remember your power play. And then move. Don't just talk about it. Don't just come to this thing and let it stay and stick in this room, and then we forget to tell the people that are out here that have missed it. Remember those 3 areas that have missed it. Help them by passing along the information. And lastly, as I take my seat, I'm proud of you guys. I am proud of you for taking time out of your day-to-day and coming to get some information, not only just for you, but I know you all learned something in here today. I know that something has palpitated your hearts to the point where you are like, I need to do more. And so today, I'll leave you with this. 3 things, as my teacher teaches me. That's right, those of you can hear my voice, I see you writing, and thank you. Number 1, advocacy is forward. It's moving forward. Advocacy is helping and assisting you and someone else. Number 2, while this is a weighty situation, it's important. And it is important to take back to your own networks, folks that you don't see, folks that you don't talk to, and let them know about something that you've seen and heard today at Martin University that continues to put on events after events after events for the community and need to be better attended. So let's tell somebody about what we've seen and we heard. And lastly, call to action the Indianapolis community to get involved at a larger level. Get involved at a larger level. It doesn't matter what organization, it doesn't matter what side of town they're on. Let's continue to support one another. Let's continue to support organizations that are out here, boots to the ground, and actually doing the work. As I said before, I really appreciate the time and opportunity to speak with you all today. And I really hope And my thoughts are with each one of the survivors that are here. I would be remiss if I didn't say I stand with you, I stand for you, and I'm praying for you. My name is Nadia Miller, and I'm a 16-year breast cancer survivor. It's sign language, guys.
Thank you. So we're going to ask you to go ahead and stay at the podium for a few moments. Really quick, did anyone have any questions or comments for our keynote? Yes.
How old was your daughter when you started diving into details so that she would be informed about what her family history was that she might be encountering?
I didn't hear your last part.
How old was your daughter when you started sharing that family information so that she would know what hereditary issues she would be up against?
8. She was 8.
It's never too early. Get my steps in.
Thank you. I personally want to thank Pink Forever just for being an amazing organization. I know as a survivor, Pink Forever has been there every step of the way since I have known of this organization. But I want to ask, how can people who are not directly affected by breast cancer, but maybe just want to help out, how do they get involved?
With the organization as a whole, or just period?
With the organization.
Well, to get involved with Pink Forever, I mean, our website is pinkforever.org. Also, our main contact at the organization is Lisa Hayes, and we have and they're in the room. We have breast health advocates that are not only survivors, but we have folks in the lay community and also the medical community that help further our mission under the 4 pillars of research, empowerment, education, and supporting individuals. And so how you get involved, honestly, the best way is to either call or just go to the website. And Pink Forever's in the community. I mean, that's another thing. We are absolutely in the community. And it's far reaching beyond those that, I've had a couple folks come up to the table and say, hey, we haven't, heard about it. But now that you have, tell somebody about it. And we welcome you and all of our programming to be a part of what we are continuing to do here in this community and abroad. Thank you.
Thank you.
Thank you. Was there anyone else that had any questions or comments for our keynote? All right, well, Nadia, thank you so much for that wonderful address. Can we all go ahead and give her a round of applause?
Thank you.
We're going to ask you to stay up here again. We're going to ask you to remain up here again. I am so sorry. I am so sorry. All right, so before we have Ms. Miller sit down, I want to go ahead and invite the newest member of the NCREI team and my colleague, Joanne Johnson, who serves as the Director of Equitable Justice Initiatives for our center up here with me, to go ahead, and we're going to honor Ms. Miller for her hard work and dedication, not only with this conference, but as an advocate and survivor of breast cancer. So Joanne, if you want to. So what we have for you cannot amount to the gratitude that you should receive at all, but we hope it is enough of a small token of appreciation. Juwan, if you want to hold it up for everyone to see, we're going to present Ms. Miller with this keynote appreciation gift, a crystal 3D trophy. And next, I would like to invite Mr. Calvin Roberson from IU Simon Cancer Center up here with me as well. He's the Director of Operations, Office of Community Outreach and Engagement at IU for the Simon Cancer Center. Yes. So what we're gonna go ahead and do now is get into our partner and keynote recognitions. We, of course, want to give people their flowers while they're here with us. So we just want to take a minute to do so. Thank you. Okay. Next, I would like to invite the cancer support community up here with me. Ms. Carissa, if you want to join me up here. Yes. Cancer support community has been one of 3 primary partners in making today happen for us all. I know Dr. Huddleston thanked me earlier in his opening address, but I could not have done this without the village that is standing next to me and will continue to file on up here with me. So we want to make sure to thank them as well. And on behalf of the National Center for Racial Equity and Inclusion, we want to present cancer support community with a token of our appreciation as well. There we go. All right, so on behalf of Cancer Support Community, Ms. Chris, we want to present you with your trophy. All righty. And next, we want to invite, even though she is holding her phone taking pictures, we want to invite Ms. Lisa Hayes up here as well. She was also another one of our key primary partners in today's conference, from recommending Ms. Miller to me to providing us with some of our panelists that you all heard speak today. We want to thank her as well. Thank you. Thank you all. And if everyone would like to go ahead and be seated besides Mr. Roberson, that would be greatly appreciated. Thank you again. Yes. All right. So, no, you can keep holding it. We're going to recognize you next. So, yes. So, even though he already has his trophy in his hand, I want to take a moment to recognize Mr. Roberson specifically. So, from the moment that I had the idea to host a conference on cancer a few months ago, he was the first person I spoke with, and he helped me lay the groundwork and foundation for today's conference, from the research to the statistics to make today what it was for all of you attending. So I just want to make sure I give a special thank you to such an intricate partner for today's conference. And wanted to present you on behalf of the National Center for Racial Equity and Inclusion, you specifically in your department at IU Simon Cancer Center, with a token of our appreciation. So thank you. Yes. Yes, you get to sit down now. Thank you. All right. So again, thank you for everyone that was key in putting today together. I want to continue thanking the village, even though he had to step out and give a DEI foundations training, because I hold an event, David still has things to do. So even though he's not here, I would like to thank him as well for his leadership and guidance for allowing me to put today together. I also want to thank the rest of my team. So I want to thank Mr. Jawan over there, who is stacking the trophy boxes, for his help in helping me put today together. I'd also like to thank Sierra, who is sitting over there at the NCREI table, who has helped me out today as well. I'd like to thank our live production team, who have been running around all day, making sure that those joining us virtually have a good experience as those do in person. And anyone that I forgot, I'm so sorry, but thank you. All right, and as we wrap up the virtual portion of today's conference, again, I'm going to do a non-shameless plug of the lovely surveys that we, again, ask you all to take, especially those registration surveys. Again, we want to make sure we demographically have a good assessment on how to best serve the community that attended today. We also ask you to take the evaluation survey for today's conference, just so we can have a better understanding of what we may need to change, what we need to keep, and how the audience enjoyed the flow of today's conference. Lastly, there is a community forum survey provided by IU Health Simon Cancer Center that we all ask you to take as well, as they have the same purpose for doing the research as well. So that concludes the virtual portion of today's conference. Those of you joining us virtually, we'd like to thank you for attending. We do have more Events coming up as the center. Next on March 21st, it is a Tuesday from 12 p.m. to 1 p.m. will be our Talk About It Tuesday Health Equity Series, where we will have a guest speaker come and speak to the community about a certain topic in health equity that affects the minority community. So be sure to be on the lookout for that. You can also search it on Eventbrite at Talk About It Tuesday by the National Center for Racial Equity and Inclusion to sign up for virtual tickets, and you will get a Zoom link. For those that are still joining us in person, we'd like to thank you for taking time out of your Friday to be here with us today in the physical. Next, we're going to transition to the Community Organization Resource Fair. So these lovely organizations and tables that have been here all day, some of them since 8 a.m. as early as some of them, cough, cough, in lung cancer now. They would love for you to speak with them, even if you are not in need of their services. I ask that you network with everyone here, just because you don't know what resources can be provided or who you could have resources for.